we have 3 fabulous speakers for you and lots of opportunity for discussion afterwards. So before we get started, I do want to provide a land acknowledgement, and I would encourage you to post your location as well in the chat line if you would like to do that. I would like to acknowledge that we are gathered on traditional territories of First Nations and Indigenous peoples in Canada. And I, in particular, am located on the traditional unceded territory of the Wolastoqey people. This land along the beautiful Wolastoq River, the St. John River in New Brunswick, has been home to the Wolastoqey people forever. And I would honor their enduring presence, their culture, and their stewardship of these lands and waters. And we are mindful of our responsibilities to walk in respect and in partnership with Indigenous peoples and to contribute to reconciliation in meaningful ways. So please join me in taking a moment to thank the people of this land for allowing us to be here. We have several polls that we would like to start things off with, just to get a sense of who people are and where they are from, what kind of location they're in terms of their job, their role. So, Tanya, do you want to post the first poll that we have? So if you can complete this poll, we'll leave this up for a couple of minutes or a minute. For you to identify where you're from. Oh, South Florida. Boy, that's a distance. North York. Aris, Ontario. Great. Great to see you all.
And I'm going to end the poll in just a few seconds. Chicago. We have someone from Chicago. Welcome. And of course from Guelph. Welcome.
And Lake Simcoe out of Wasaga. Great. Wonderful to see you.
And I'm going to end the poll right now. Thanks, everyone.
Great.
And I'm sharing the results.
Great.
We have a number of nurses, social workers, education researchers, policy program planners, and some other healthcare recruiter. And more from Florida. Welcome, Florida, today. From someone from, good morning. This is Tanya Tercero, Assistant Nurse Manager, Broward Health Medical Center, Fort Lauderdale, Florida. Got lots of Florida.
Yeah, great to see. Oh, St. John's.
And St.
Yay,
John's.
The Rock.
Yeah.
Welcome.
Yeah, you're very welcome for the symposium. We're so pleased to be hosting it today.
Do you want to put up the second, Tanya?
Mm-hmm.
So primarily nurses, social work, mental health work, educator, researcher, policy program planner.
And here comes the second poll. Just want to give everyone a chance to reply. If you've just joined us, we've got a poll up. If you'd like to respond, tell us a little bit about who you are. Okay, looks like everyone's complete. I'm going to end the poll now and show the results. There we go. Got a few people where it's brand new, and there's a variety of experience in the room today. Okay, I'm going to stop sharing the poll. We've got a real variety in here today. Thank you all for joining us.
Mm-hmm. That's excellent.
Yeah. And I'll throw it back to you, Rosemary.
Thank you. Thank you very much. So it gives me great pleasure to introduce Ellen Telegdi, and Erin is the manager of advanced clinical practice, substance use and mental health at South Riverdale Community Health Centre in Toronto. She's a practicing nurse at the Moss Park Consumption and Treatment Service, Casey House, and the Wound Healing Clinic at Women's College Hospital. Erin is a Master's of Nursing student at the University of Toronto and is passionate about community-based healing for people who use drugs. Our presentation with Erin this morning is based on wound care and harm reduction when evidence clashes with stigma. So I'll turn it over to you, Erin.
Thank you so much, Rosemary. And I'm going to share my slides. Okay. Thank you so much for having me this morning. I'm really happy to be here to talk a bit about wound care. And I believe we have, Rosemary, can you confirm until 9:45?
That's correct.
Okay. Just so I can keep an eye on the clock. So a little bit about me. Rosemary gave a bit of an introduction. But I wanted to expand a little bit. So this is a photo of me from 2020, which you may have guessed based on how I am dressed in the photo, outdoors. But anyways, it was a time. So I've been a nurse since 2013. I started my work at Casey House, which is a subacute care hospital for people. At the time, it was for people living with HIV. It's expanded its mandate to be for people at risk of or living with HIV. And I was working there, and it was the summer of 2017. And I saw on social media that there was this call out that this overdose prevention site was going to be opened up in Toronto's Moss Park, and they just needed registered health professionals to volunteer. Really, just because they needed registered health professionals there. That was the agreement that they had made with the city and with the Toronto Police Service, that no one would interfere with the operation of the overdose prevention site. And one of the stipulations was as long as you have a registered health professional. So I was just there for my letters, but I was happy to volunteer. And I stayed with that, with the OPS throughout the course of its operation. And then it transitioned to a sanctioned site, and then I started working there. And so I've been working in the Moss Park community for 8 years now. And it's a big part of my heart. I love nursing, except when I don't, but I love nursing. And I love working in and with community. And I'm here today because I also have particular love for providing people with good wound care. So this is a picture of me from the summer of 2020. No one knew what was going on yet. There were a lot of new rules in place. There was a big encampment in Moss Park, and I would go out with my colleagues every day to the encampment, and that's where we would provide wound care and other health services. So that's a bit about me. And it would be remiss of me to also mention that I, right now, am living on territory that Its original law is the Dish with One Spoon Wampum Belt Covenant. It is Treaty 13 territory, which is a treaty between the Mississaugas of the Credit of the Anishinaabeg Nation and the British Crown. So I am in what is now known as Toronto. Today, we're going to talk about managing wounds in people who use drugs. We're going to debunk some myths about wound care and substance use. And we're going to talk about the ethic of non-judgmental care. And I'm just noticing now that it looks like I didn't number this correctly, so my apologies. But I also wanted to provide a content warning, and this is the first time that I've ever provided a content warning, and actually the photos that are in my slide deck are tame compared to some of them that I use when I present on wound care. But it occurred to me that not everybody is desensitized to seeing wounds. So this is just a heads up that there are some photos of wounds in this slide deck. And they are all apart. They're just the photos of the wounds, but the wounds are on beautiful, amazing people that I have had the honor of working with. All right, so we will get into it. So this is, in a lot of ways, the roadmap that I live by as a person practicing wound care. This is a resource from Wounds Canada. You can Google it, you can download it. It is the wound bed preparation paradigm that was developed by Dr. Gary Sibolt and his team. And he is somebody that I have learned a lot from in the wound care world. But this is sort of like the roadmap that they've presented about how we approach wounds. So we have the person with or at risk of a chronic wound, and just put a pin in that because we'll come back to that. And then all the steps we go through. So we're identifying and treating the cause. We're considering the patient and family-centered concerns, determining the ability of the wound to heal. And then we think about local wound care. So our debridement, inflammation, local infection, moisture management. We think about edge effect. And then we also think about the system. These are all parts of the picture. And I think sometimes when we think about wound care, we're like, well, what do we put on the wound? Well, that's just like one small piece of it. There's this whole bigger picture that we need to be looking at too. And I think a lot of us who are working in wound care, we're mostly working with acute wounds, but there are a lot of risk factors in the folks that we're working with that can lead to acute wounds becoming chronic. So I'm sure if you've been working in wound care and you're a nurse, or you've been working in harm reduction, you may have seen some of these common acute wound presentations. We have abscesses, we have cellulitis, burns, lacerations, scratching and picking, and sometimes drug-induced. Now, this picture is of, a very frank cellulitis. We can see that like hot red erythema, I outlined it in red. We had a conversation. If it goes beyond this, in 24 hours, please come back. Let's try to get you on some antibiotics or go to emerge or whatever to help people sort of themselves see if the erythema is getting more or less, if things are getting better or worse. And cellulitis is the only one of these acute wounds here that's listed that absolutely requires antibiotic treatment. The others, not necessarily, not necessarily. They may develop infection, but in and of themselves do not require antibiotic therapy. And I will say, and put in a big plug for the fact that please, 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 if you are not familiar in the signs of cellulitis and signs of infection in a wide variety of skin tones, please take the time to learn this, because we know that there is a huge amount of inequity in outcomes in dermatology, because so much of the learning that we do is on light skin tones. And so symptoms get missed in people with darker skin tones. There's a good resource, and I have a resource page at the end that you're welcome to take a photo of, but Mind the Gap, a handbook of clinical signs in Black and brown skin, is a really great resource for that. And then I will also point your attention to the Katie Stop Signs tool that is available for download from the Katie website. And this was a tool that was developed with people who use drugs as a way to help people identify if there are signs of infection that are happening, and some guidance around what that might look like and what to do if these signs present. So this is a great resource that I would encourage people to download and put up in your clinical spaces for folks. So, and then in this photo, we have a person who had some cellulitis, because even though we're not seeing frank red erythema, we do see change in the skin tone, the shininess, sometimes dimpling. There are other signs of cellulitis, like the warm to touch skin. There are other signs of cellulitis other than just the frank red. This wound was absolutely, this person's arm was absolutely showing some of those signs. Okay, so we've talked about acute wounds, and then we also have this category of chronic wounds. So I think it's really important to think about that distinction. Is this a chronic wound or is this an acute wound? Because your approach is going to be different based on whether the wound is chronic or acute. And I love my community health nurses. And I also know that we just love to use like wildly expensive products. So I do a keep it simple approach. If you have like a pretty straightforward acute wound, like keep it simple, and then bring out those really expensive dressings when they're needed, when they're indicated, like the super absorbers. I mean, if there's somebody watching your who pays attention to how much you're spending on wound care supplies, they're going to notice if you're like really going through the super absorbents really fast, or like the silver products. So we want to make sure that what we're using is indicated, and we can keep things simple. We really can. We don't have to get complicated with wound care. But chronic wounds are wounds that have some like underlying issue that is preventing the wound from healing. So some chronic etiologies are neuropathic foot. So historically, we've sort of understood this as like, wounds related to diabetes, like in the foot. And we're sort of broadening our understanding of that to be more about like neuropathy in the foot and the impact that has on chronic wound risk, and also risk of amputation. And there's pressure injuries. So anytime somebody's using a mobility device, we want to be thinking about, are there areas of pressure potentially happening? But also if somebody is sleeping for long periods of time and not moving around a lot, which can happen if you say are somebody who uses opiates, you might be sleeping and not your body's not naturally readjusting itself. So that could be a pressure injury risk. We also have wounds that are related to inflammatory and autoimmune diseases. So I think pyoderma gangrenosum is like the most, the classic one. And then we also have wounds related to PVD, so arterial disease or venous disease or both. And these are all things that can happen to anyone, whether they use drugs or not. And I think, with the inflammatory and the autoimmune, I think one thing we do see in the folks, or that I see in the folks that I work with, is yes, they're people who use drugs, but I think more significantly, they're people who are living with housing insecurity, food insecurity, and the kinds of things that would put your body into a perpetual state of inflammation due to stress. So those are the kinds of things I think about as risk factors. And this is really where I think we start to debunk some of the myths. So injection drug use does not equal complex wounds. There is not like a straight line there. There are always risks associated with venipuncture, whether it's someone self-injecting or someone getting blood drawn. And some substances, whether illicit, like methamphetamine, or prescribed, like chemotherapy, can be hard on the veins, and there's a risk of complication there. But the biggest thing I think we can do is to really start from a place of understanding that just being a person who uses drugs does not necessarily mean that you're going to get horrible, scary wounds. But being a person who does not have safe access to drugs or access to safe housing or food, all of these things definitely put people at risk for developing chronic wounds. And so xylazine, and I have to talk about this because everybody wants to talk about xylazine. And it's definitely something to be concerned about because the increasingly toxic drug supply is a concern in lots and lots of ways. And I also think it's interesting how the narrative around xylazine and wounds has really been sensationalized. And I think it actually adds to the stigma that is put on people who use drugs. And I pulled this headline from a Google search, but flesh destroying drug, like it's so sensational. Like, I mean, is not every wound sort of indicative of, some skin breakdown, but flesh destroying, oof, it's very sensational. What do we know about wounds and xylazine? Well, we know that there's literature going back to the early 2000s from Puerto Rico, where the association between wounds and xylazines was first noticed. So a lot of that research was done in Spanish. In terms of research done in English, it's really only starting to come out in the past few years, where a lot of work has been done on this in Philadelphia. So there's more research starting to come out, and we are starting to see that there are other licit drugs, like drugs that get prescribed to people, that have similar properties and similar kind of dermatological effects. So the picture around the mechanism of action of how xylazine contributes to wounds is becoming more clear. It is mixed into the illicit drug supply in varying degrees in different places. The wounds are described as sort of like a wet necrotic wound. They're slow to heal, more prone to infection. And so a clinic in Philadelphia proposed this like DIME sort of paradigm for managing these wounds, with DIME being like devitalized tissue, infection management, moisture balance, and the peri-wound edge. And I've included this in my resource page too, so if you want to look more into that. And I have to say, in my own practice, I have not seen the kinds of like xylazine-related wounds that come up in the literature from Philadelphia. I just haven't been seeing it. I don't know if others have. I think maybe some xylazine-related wounds I've been seeing with some, necrosis, slower to heal. But it's sort of like a picture that looks different based on your like local landscape. And then I'm going to come back to my wound bed preparation paradigm because the thing about it is your local wound care is still going to be the same. So you've got a necrotic wound, you want to get some autolytic debridement happening, you want to monitor for signs and symptoms of infection, you want to get your moisture balance right. You're going to do all of the same things that are the basic principles of wound care to manage these wounds. And this is all a stopgap measure unless we can address the underlying cause And treating the cause, I see as sort of, you're treating the cause, you're also treating the system. So the cause may be underlying health conditions or immunosuppression that are contributing to wound chronicity or the complexity of wounds. Absolutely, the toxic drug supply is a cause. So on a systems level, we're thinking about, does this person have equitable access to healthcare, to housing, to a place to shower, to food, to socks, to weather appropriate shoes, to skin moisturizer? Do they have access to supervised consumption spaces? Do they have access to a safer supply? So we know what we know about xylazine. We know that there's an association between xylazine and wounds. And I don't know what could be a more compelling argument for the need for safer supply of drugs. Okay, but you're probably thinking now, okay, lady, but what do I put on the wound? Because everybody wants to know what to put on the wound. But it's not just about the dressings, okay? It's also about the plan. So we have to be thinking about how frequently does the dressing need to be done. Not every dressing needs to be done daily. Some do. If there's a lot of exudate, you don't want it to be macerated. You don't want to create more maceration. Daily, maybe if it's like fresh post incision and drainage of an abscess, then yeah, sure, daily is absolutely indicated. But for chronic wounds, daily dressing changes aren't always indicated and sometimes can disrupt the healing process. How do we assess wounds? So I am a big fan of implementing standardized tools. And in fact, my team is just in the process of, for the first time, implementing a standardized wound assessment tool. And we're like a big organization. So this is a exciting and necessary step. So we're using the Bates-Jensen wound assessment tool. That is one validated tool. There are lots of others. So find a validated tool that works for your team and your context, but find a way to use that common language, that common assessment amongst your team. And then it also helps you with communication with people who maybe are also part of the team, but outside of your organization. And then so you can actually see if the wound is closing or deteriorating or the ways in which it's changing. These things are important to assess and document in a consistent manner. And then to have a plan for what the dressing protocol is going to be, and then stick to the protocol. Everyone on the team, just do the same thing for give it 2 weeks, unless it's going really badly, then obviously change. If it's making it worse, change it right away. But give something a bit of time to see if it's working. What I see a lot that is not so helpful is every nurse just kind of does their own thing and puts what they want to put on a chronic wound. And then it's really hard to tell what's helping and what's not. And some things are making it worse. Some things are making it better. Some things don't work. Some things don't work for the person, or they have preferences and those aren't being taken into account. So I think it's really good to have a plan that makes sense from a clinical perspective and also makes sense for the person who's wearing that dressing in their daily life. And figuring out, where and when you're going to do dressing changes and who's going to do them. So for a lot of the folks that I work with, they maybe have a partner or a family member or a friend who is very invested in their wound healing. And so, you're doing the wound care, you're explaining to the person with the wound, why you're making the choices you're making, and then you're making decisions together about the thing. But then also bring in that friend who might also be helping with the wound care and do that teaching and sharing with them as well. I'm a fan of giving people to-go kits because maybe you're not going to see them for a few days, but they're going to need a dressing change. So why not give them a little care package to go home with or to go out into the world with? And then another important piece that I've been learning in my life as a community nurse is figuring out how to find people, because not everybody has a working phone. So like, do you have a friend who has a working phone, or where do you tend to go if you're not here? Where can I find you? How can I find you? Who can I ask? And say like, hey, have you seen so and so? Like really figuring out that circle of care that includes healthcare professionals and like formal services, but also figuring out the informal circle of care, the people that are holding people in community. So getting a really good sense of that, getting consent to talk to folks so that you're able to find people when you need to find them. And then also considering, what do you have access to and what do those products do? So I've put here the wound dressing formulary, also from Wounds Canada. And so the wound dressing formulary, it kind of gives you all of the different categories of dressings. And then you can look in your own dressing cupboard. And they have ones that are like, you can use a dry erase marker on. So you can say, in this category, we have like this brand of dressing. In this category, we have this brand of dressing. But look and see what you have. You want to make sure you have a certain basic repertoire of options. So you want to make sure that you have, a super absorbent. You want to make sure that you have a cleanser with some surfactant. You want to make sure that you have a decent foam dressing. You want to make sure that you have good antimicrobials with a range. So maybe you want to have, if you have the budget for it, a bit of silver. Maybe you want to have some povidone iodine. Maybe you want to have some povidone iodine impregnated gauze, some chlorhexidine impregnated gauze, some silver impregnated gauze. Like, figure out what you've got and then where you're missing and try to fill that in. And I think the most important thing to remember, though, is that you can put gold and diamonds on the wound and the most expensive wound care products in the world. And none of that matters if you're not able to address the underlying cause of the wound. So that's why that's at the very top of that wound bed preparation paradigm, treating the cause. What you put on the wound is such a small piece of wound healing. Like if a person has venous stasis disease, sorry, this is a bee in my bonnet and I'm always saying this. If a person has wounds related to venous stasis disease, they are going to require compression. There's a whole process to getting like high compression onto someone. You have to make sure that they are arterially competent. They'll be able to tolerate the compression. But if you've done that piece and the person can tolerate compression and the wound needs compression, it doesn't matter what you put, like what dressing you put on the wound. If you don't have the compression, the wound's not going to close. Or it might start closing, but it'll get worse again. Or it might close, but it'll reopen. And we always have to think like every time a wound closes, we lose some tensile strength. And I think they say the first time it goes back to like 80% tensile strength. And then like the percentage keeps going lower after that. So once there's a wound, there will always be a risk for re-injury at that site. And that's why like the treating the cause piece is so huge, addressing those underlying factors. Developing this care plan that I've been talking about takes time, and it is an iterative process, which for folks and in that poll at the beginning, it looks like a lot of people are working in harm reduction on a daily basis. So I know that you know this, that it takes time and it takes trust, and it is an iterative process. So you're going to try things, you're going to find things that work, and you're going to get feedback sometimes that things are not working, and that's okay. One thing I always want to ask folks, because I work a lot in particular with people who inject drugs, is this dressing that I'm putting on you going to get in the way of anything? Because if somebody only has one vein that they can access, I want to try to avoid covering it up, right? Like those kinds of considerations matter, as well as when are you going to be able to take a shower? Should we try to plan our dressing changes so that it's after you take a shower? Because if you put a dressing on someone and then they go back to maybe a shelter that they're staying at, and that's the only place where they can have a shower, and it's in the evening, then you're not really like planning in a great way. So thinking about like the context of the person's life, getting to know people, getting to know their routines, getting to know the things that are important to them, all of those things are going to help inform our wound care plan. And again, there's lots of harm reduction folks in this group, so you know these things. We're meeting people where they're at. We are always working in collaboration with people who use drugs. And those relationships matter. If you're working in the community, if you're a community nurse, you know this relationships matter, and healing happens in community. And I just love this image. It's by a Two-Spirit Cree Toronto-based artist, Sean Howe, who has beautiful murals all over the city. So if you are ever in Toronto, or if you're already in Toronto, I would encourage you to go check out their beautiful work all around the city. I think at the root of good wound care in a harm reduction setting is thinking about having a really broad understanding of who the team is. It's not just healthcare professionals, it's also community. So who's on the team? What is available to us, and how can we leverage resources? What is the person's preference is always at the center. And we're looking at what the wound needs. A wound will always tell us what it needs. If it's too wet, we want to help make it a bit drier. They say the wound bed should always be like the moisture level of an eyeball, which I actually find to be a really gross comparison, but that's what they say. So we want to have that moist wound healing environment. So we don't want too dry, we don't want too wet. So looking at the wound and asking the person, how fast is this dressing soaking up? Getting that information. This is all helpful information that will help us to guide the decision making around what dressing intervention we are going to choose. And I've just included this photo from my workplace because Moss Park is my whole heart. And this is a piece that one of our community members made for us, and they included all the folks on our team in this lovely tribute, I think, to the nature of community and working in community. So I want to thank you all for joining me today. I hope I have piqued more interest in providing wound care in a harm reduction setting. And since I have a little bit of time, I'm going to tell you the story behind this photo because I love this photo very, very much. So this is a picture of somebody cooking their fentanyl on the flame of a birthday cake candle. So this is a person at the Moss Park injection site where I work. We always make a big deal about birthdays. We love to celebrate birthdays because you just think in a community that's lost so many people, man, if you get to celebrate a birthday, that's like a pretty awesome thing. So it was this person's birthday, and we were waiting for him all day. We had this big cake ready for him. We were going to go all out for him. And we were waiting for him all day. All day, he didn't come. It was kind of weird because he was there every day. And we were waiting for him, and he didn't come. So it was the end of the day, and the team, we were just doing our little kind of debrief that we do at the end of the day. And then we hear this knock on the door. And so someone went and opened the door, and it was the birthday boy. And so we were like, oh my God, happy birthday. And he came in and he was just like, okay, yeah. And he's like, I really need to do a shot. He said his he had gotten all of his stuff stolen at the shelter he was staying at overnight. So all of his money, his drugs, everything. So he'd spent the whole day just kind of hustling around, trying to get some money together so that he could buy some fentanyl. He was really feeling sick. He was in withdrawal when he came to us that day. And, we usually wouldn't be, we try not to let people in after we've closed, but it was his birthday and, we could see what was happening. So we're like, okay, yeah, come in and do your shot. And so he starts preparing his shot, but we're still so excited that it's his birthday. So someone went and got his card, and someone went and got the cake and lit the candles on the cake. And then, so he's prepping his, trying to get a shot together. And then we come busting in with singing happy birthday, and we've got the cake and whatever. And he was kind of, a bit stunned. He was like, I hadn't even remembered it was my birthday today. No one said happy birthday to me yet today. And we were like, well, we knew it was your birthday. We're really happy to see you. And he was like, okay, this is really nice, guys, but can I do my shot right now, please? And then we'll have cake. And we were like, yeah, okay. And so that's what we did. And that's where this photo is from. So since I had time, I wanted to tell you that really nice story because it makes me very happy. This is a slide. Please take a photo of it. These are resources and references, most of which I mentioned during the presentation, some of which I didn't. I would give a shout out to the NSWAC Wound Care Community of Practice, and their Google group there are people with a particular interest in wound care and harm reduction that have developed a community of practice. And then I think I'll give it back over to Rosemary.
Thanks, Erin. Just leave that slide up, I think, for a minute, because this is something that is really of benefit to the attendees of the webinar today. So just want to, I'm a wound care nurse as my kind of basic background, and certainly Gary Sibbald is one of my mentors, and many of the people that that you reference here are people that I know well. But I just want to say how terrific it is to listen to someone who is in the trenches, really at the forefront of being able to provide this kind of care for people that we certainly, when I started, working in wound care, was just tip of the iceberg kind of thing. And particularly your focus on the individual and how important it is to recognize that it's the person. I always used to say to people, it's not my wound, it's your wound. And so it's really wonderful to have, again, sort of your perspective on what the key important things are for people to really remember. And one of the points that you made that I actually wrote it down because I thought this is really great is, how can I find you? Because I think one of the biggest issues around helping people who are living in vulnerable situations is being able to get back in touch with them. Many patients that I've had in the past, dealing with wound care or other things, they disappear. They disappear from view if you don't have other ways of being able to reach out to them. So, I think that's one of the really important things that you bring up here. So I want to,
Can I add one thing there?
Oh, yeah.
I think I love that you picked up on that point, and I think what we're also seeing, certainly where I live, but I think also across the nation state of Canada, I think also across the nation state of the US, is that people are being constantly displaced as well. So even if people want to stay connected to you as a care provider, and want to find you, people are constantly being displaced. And I think it's important for us to also have that framing, because it's not that people are necessarily disappearing, although sometimes it is. Sometimes people are trying to do a different thing, but sometimes people are being pushed out of their communities of care.
Yeah. Yeah, really good point. Really good point to make. And it's one of those things that, it's a small detail that we need to keep in mind when we're looking at the bigger picture as well. So yeah, great,
Totally.
great. And you're right, we need to come up with a different way of describing moist like your eyeball. I agree. It's kind of a weird thing. So
Yeah.
I want to really thank you, and please, stay up here. And I want to open the opportunity for people to ask questions, to in the chat line. So please feel free to bring up some questions. And I'm going to start with one that is really I think is one of the another sort of issue that we certainly see a lot, and that has to do with skin tone. So really being able to do a better job. So I know you talked a little bit about, what to look for. Can you maybe talk just a little bit more about, for healthcare professionals, for people who are, and for harm reduction workers who are looking at skin, what are some of the tips that you can suggest when you are looking at people with different skin tones to be able to assess, for example, the cellulitis or the development of some kind of issue going on with their skin?
I think the biggest thing, and this is a lesson that I learn again and again and again, is that people know their bodies best. So if someone tells me something is wrong, this doesn't feel right, this is different than it was, listen to people. They're 100% right, 99.9% right. And I actually mostly learned this through with venipuncture, to like drawing blood on somebody. If they say, no, use this vein, and I'm like, no, but I think this vein, no, they're always right. But I think this is also true of people's like self-assessment of skin conditions. But there are lots of other signs that have to do with skin texture. So if skin is getting kind of taut and shiny, that's a concerning sign of infection. If you feel crepitus, so like it feels like a little bubbly, if you kind of just touch the skin, that's like a really big red flag that you want to address right away. The history, like how long has this been happening, and how fast it's progressing based on the person's report can give you a sense of the urgency. Vital signs, of course. If you're worried that somebody has an infection, you're going to do a set of vital signs, right? Because you want to know if you're worried about systemic infection or if it's local infection. Sometimes you can treat just with topical antimicrobials for, kind of what they call critical colonization in the wound bed. But then there are other times where, like with cellulitis, where you are going to need an oral antibiotic on board. And so, yeah, do a set of vital signs. The dimpling in the skin is another sign that you can see across skin tones. So I think just moving away from that, like red equals cellulitis, is really important, because also then people see two red lower legs and they're like, oh my God, there's bilateral cellulitis. There's rarely bilateral lower leg cellulitis. So actually, if you're just seeing two red swollen legs, lower legs, you wanna be thinking about some other things too.
Right. Yeah, and that's great. I mean, I think the big thing is to really look and ask. Yeah, asking is very important. Yeah, for sure.
I know.
So we have a question in the chat line recommending how you would help healing the hidradenitis or the HS wounds. So maybe know the importance of treating the underlying cause, but after treatments, laser, silver creams, how to heal these little wounds. And they're complex. Yeah.
With patients. I think you have all of the pieces in the statement. So definitely you want to be using anti-inflammatory local wound care. And I'm actually really
glad that you raised this, because just yesterday I was looking, a colleague sent me a picture of a wound, and sort of sent me like the wound, 2 weeks ago and the wound today. And I've never seen the wound in person, but she said, this is what 2 weeks ago and this is what it looks like today. And the picture from today, it was extremely hypergranulated. And then I looked back in our charting and I was like, oh, we keep putting povidone iodine product on this wound. And so I put a call out to the team. I was like, halt, no more povidone iodine, because it's actually pro-inflammatory. And so if you have a wound like HS, for example, that has an autoimmune, like an underlying autoimmune etiology, you want to be mindful of the products that you're using to make sure that you're not using pro-inflammatory things that will irritate an autoimmune related wound. But yes, they're extremely complicated to manage. If you're doing all of the treatments, the lasers, I'm assuming steroid injections are in there somewhere. I think patience and packing where it's tolerated, but they're also very painful, right? So I appreciate the challenge of these wounds, and I'm not sure if I've helped you at all, because I think you've covered a lot of the basic things in your comment. Rosemary, if you have anything to add.
No, I mean, these are the sort of they are the complex kinds of things that you're dealing with, because they're essentially hair follicle inflammations, right?
Mm-hmm.
So, and I think one of the other things often is that they can be mistaken for other things, right? Like they can be mistaken for an infected injection site. I mean, sometimes they are, because people are injecting in that area anyway. And I think one of the other, these are, we're going to talk a little bit later, I know, about stigma. And I think that that's another place that people often, that would be another question that I have for you, in terms of, in the way that you approach your clients or your, the individuals that you're seeing.
Mm-hmm.
Are there any tips, again, that you can give to the audience here about, what are ways to talk to people about exploring some of the skin issues that they may have but may not want to talk about?
I think this is true of community nursing in general, and it's the magic of community nursing or working in community, is that we know that it's the centrality of relationships. So as you get to know people, and not just on a clinical level, the thing I love about my work is I get to spend lots of just sort of free time with people. So we're not talking about their health problems. We're just talking about life and things and movies and music and whatever. And so I get to know people as people first, and they get to know me as a person first. And then from there, I think people will approach and be like, hey, since you're a nurse, I'm having this concern, or I'm having that concern. And I'm sure that Madison and Mish would agree with that, like that centrality of relationship is so important. Because I think, and then also being in a harm reduction setting where people know coming through the door that there's an expectation that they will not be judged because they use drugs, I think is a big facilitator to being able to provide healthcare. And I'm often saying to people, like, this isn't happening because you use drugs. Like, this wound did not happen because you use drugs. Because some people will be like, oh, I know, I just need to stop using drugs. And I'm like, no, that's not it. That's not what caused this wound. Let's be creative thinking here, like, not everything is about drugs. And it's not. So I think those are some of the ways that I just sort of live my professional life, and develop good relationships with people.
Right. Really, really important. So Patrick has said here, amazing job, Erin. I love what you said about, taking in the whole picture and the centrality of relationships. So his question here is, do you see any parallels or intersections between our principles of wound care for physical wounds and our care for psychosocial wounds? Ooh.
Is this the Patrick I think it is? If it is,
It's just Patrick, so yeah.
I don't know. That's like brilliant. You should okay, let's write a paper about this, Patrick. I think that's beautiful. I love that. Yeah, I absolutely see parallels. Madison's gonna do it too. Okay, we've got it. We've got some scholarship happening
Great.
already. That's such a beautiful parallel, actually, Patrick, because yes, yeah, yeah, the wound is a metaphor, right? It's a powerful metaphor. And in spending time with people, in being in physical close proximity to people, which is something that happens when you do wound care. Like, I do this thing when I'm, I don't know why, I learned it from, oh, nurse Margie Newman from the wound care clinic at Women's College Hospital. But she does this thing that she taught me that I now do, is that when I'm doing a dressing that requires a compression wrap, so doing a compression wrap is a pretty physically involved process, and you got to get some leverage to it. So if or even if I'm putting on like a oh, I don't want to say brand names, but the tube socks, I'll put someone's foot like on my shoulder so I can get leverage to get the thing on, or to just get the right angle to get the dressing right. And there's like a vulnerability to that, and there's an appropriate level of physical intimacy to it. But I think when you're just close to people, when you're spending time close to people in those sort of like liminal and very precious spaces, that yeah, you're dressing a physical wound, but you're probably also addressing some other wounds too. And I think that's like bi-directional, actually. So yeah, that's beautiful, Patrick. I love it.
Yeah. Yeah, that's it. And it's a very interesting way of really being present with your patient or with the person that you're dealing with. And I just have to say here, like, what I find really amazing about this. So my PhD was actually on the nurse's experience of changing a dressing. And exactly what you're talking about were the things that, and I did my PhD like 2006, so a long time ago. But the nurses that I spoke to about doing dressings, these were nurses just in general practice, in the community, in acute care, and in long-term care. And they all came up with very similar kinds of responses around what it was about wound care that really was kind of cool, and from a nursing perspective or a healthcare professional perspective, to see the wound and to see the actions that we take as wound care specialists or as wound care providers is to really have that sense of being, this is a privilege to be touching other people in the way that we do. So, kudos to you to be sort of continuing. I mean, this is what excites me about this symposium, is that the three of you are such dynamic and engaged nurses. And for somebody like me who's been around forever, it's wonderful to see this. Like, it's really, this makes my day. Oh, and Mish is commenting here. That's really interesting. When we think about people who are under-resourced, also often being touch-starved, what a good thing to say. And that touching clients in appropriate and therapeutic ways, including during dressing changes, can be a way of decreasing stigma and showing that you don't think they're an unsafe person. Yeah. Yeah, absolutely. And one of the things that I have always taught when I teach wound care is wash their feet. Wash people's feet. Use wound cleanser, you can spray stuff on, but wash their feet, because people do not have this doesn't happen. And when you wash somebody's feet, it gives you a chance to assess, but it also gives you a chance to develop that rapport in a way that is very difficult often to that trust and that rapport to obtain otherwise. Yeah. Any thoughts?
100%.
Yeah.
No, yes. And I think I'm working on a BPSO, or my organization is part of a BPSO for lower limb preservation. And there's a lot of focus, obviously, on people with diabetes and the risk for foot complications. But I think we really underestimate the amount of neuropathy that people are experiencing in communities, in the community that I'm working with. People are on their feet all the time. A lot of them have been prescribed medications like pregabalin for like long periods of time. That can cause neuropathy. Repeat cold injury can cause neuropathy. So there are lots of good reasons, like therapeutic reasons and clinical reasons to take care of people's feet and to look at their shoes and to make sure they have dry socks. Like, yeah, I think that's so important, Rosemary.
Yeah. Yeah. And, you know, one of the things that you talk about too, in terms of when you were saying that you're fortunate to have time to be able to manage these kinds of things, like, do you have any, again, sort of suggestions for people who are maybe not working in exactly the situation where they have the freedom, in a sense, to be able to, or the independence to determine their time frame? Do you have suggestions for people who are under a little bit more of a constricted time barrier?
Oof. Godspeed. I'm so grateful for my unique, though precarious, situation where I am able to spend lots of time with people because I've seen how beneficial it is. But I think even just, whatever time you are spending with folks, just be present in it. Like be there, even if you can't be there for long. Because people can tell, like, people are so good at picking up on like any even little bit of negative attitudes that a care provider has about people who use drugs, because people are hypervigilant because their entire lives they're scanning for dangerous situations because the world is not safe for people who use drugs. So people are always like very hypervigilant and they can read you so well. So even if you don't have a lot of time, the time that you do have, be really present because that will be noticed.
Yeah. Yeah. Really great. Wonderful presentation. Thank you so much. That was fantastic. And I think generated and really is a way for us to, get more into a little bit more in depth of what we're talking about. So thanks so much, Erin, for your presentation and for remaining in the symposium for the conversations that we're going to be having further on. So thanks. That was great.
Thank you so much.
People, lots of great comments thanking you for this. And this hopefully has given people enough time to, like you say, take a photo of the references and the resources. Remember, too, that we are recording the sessions and they will be up on our YouTube channel for the Canadian Healthcare Education Network in the near future. So just to let you know that you'll have access to these as well. So thanks a million, Erin, for your presentation. That was wonderful.
Thank you so much for having me.
And enlightening in a very, in a really great way. So thanks for that one. So we're going to move on here to talk about a little bit more about getting into a little bit more of the toxic drug supply. And Mish Waraksa, sorry. Mish is going to be our presenter for today on this topic. So Mish is a primary care nurse practitioner at the Scarborough Centre for Health Communities. And she has a deep experience in safer opioid supply programs and brings a strong commitment to increasing healthcare provider understanding of the toxic drug supply crisis. So I want to welcome Mish and really looking forward to this opportunity to learn about this really important topic.
Thank you very much for the introduction, Rosemary. I'm going to be discussing today understanding the toxic drug supply. I also want to recognize that my presentation includes a lot of data from an Ontario and Toronto context, and it's so exciting to see people from across the country and even down in the States, down south as far as Florida. So some of what I'm going to talk about today is really focused on a local context, but I'll also talk about how these insights can also be applied other places. So I'll start with a little background on the drug toxicity crisis in Ontario. It's often thought to have begun around 2016 when we saw fentanyl take over the opioid supply. At this time, we're seeing about 9 drug toxicity deaths across the province every day. This chart shows the opioid present at death. At this time, 91% of opioid-related deaths are due to non-pharmaceutical opioids, primarily fentanyl. This is a big shift over the last 15 years. Prior to 2014, oxycodone was the leading cause of opioid-related deaths. In 2014, Ontario delisted oxycodone from the public formulary, meaning oxycodone would no longer be covered by public drug plans. This, in conjunction with the opioid deprescribing movement, led to a drastic decrease in oxycodone prescriptions. At that time, we began to see deaths related to heroin increase, and then within a few years, this massive spike in fentanyl-related deaths. Deprescribing was meant to decrease opioid-related harms in Ontario. However, it also had the effect of removing a large portion of the supply of pharmaceutical opioids off the street, and many people shifted to using more potent but readily available forms of opioids like heroin and then fentanyl. Oh, I hope I was on the right slide. Here we go. Stimulants, just to touch on them briefly, we do see cocaine or methamphetamine present in 60.9% of drug toxicity deaths. However, it's usually in combination with opioids, so it may not be the primary cause of death. And stimulants were the only drug present in only about 13% of deaths. So why fentanyl? Where did heroin go? We know that following deprescribing, heroin use spiked, but what happened to it and why this shift to fentanyl use? One explanation is the iron rule of prohibition. When a substance is prohibited, the black market in turn produces increasingly potent forms for better efficiency and profit margins. A more concentrated substance means smaller packages to smuggle for a larger number of doses. We saw this with alcohol prohibition, where the public generally enjoyed wine and beer as their primary forms of alcohol, but with prohibition, production and consumption of concentrated liquors rose instead. We see the same thing with drug prohibition. Pharmaceutical opioids are restricted and heroin becomes more predominant, and then heroin shifts to fentanyl, and now we see even more potent forms of fentanyl with other adulterants taking over the market. But I am going to get to those adulterants in a minute. Reasons for this shift from fentanyl to heroin also include properties of the drugs themselves. So whereas heroin is a product of opium poppies, fentanyl is produced in a lab and synthesized from precursors. So heroin production is geographically restricted to areas that can grow opium poppies. There's a lot of time required for maturation of the plants, harvesting and synthesizing the heroin itself. But by contrast, fentanyl can be produced using synthetic precursors in a lab over a day or two. Fentanyl has a much higher potency, about 50 times as strong as heroin, making it more efficient for smuggling. And these factors mean that fentanyl is 500 times cheaper than heroin if we look at their equivalent potencies in morphine equivalents. So it's much more profitable for people to be producing and selling fentanyl. To get an idea of how potent fentanyl is, the average purity of street fentanyl in Toronto is about 3.4%. So 3.4% of the substance that someone's actually purchasing is made up of pure fentanyl itself. A gram of purchased fentanyl contains 34,000 micrograms of fentanyl per gram, which is equivalent to about 10,200 milligrams of oral morphine. By contrast, most guidelines recommend a maximum of 30 milligrams of morphine per day for someone who has severe chronic pain, and a starting dose of methadone is equivalent to about 200 milligrams of morphine. We use fentanyl medically for its short-acting sedative and analgesic properties, often for things like procedural sedation, like setting a bone or a short procedure. And an example of a dose would be 40 micrograms of fentanyl for the procedure. So someone using a gram of fentanyl per day would be receiving the equivalent of 800 times this dose. It's important to understand just how profoundly high people's tolerances are when they're using street fentanyl, and I hope this gives sort of an idea comparing to morphine and the use of fentanyl in medical settings. But what is fentanyl when someone's purchasing fentanyl? Of 1,777 fentanyl samples submitted to Toronto Drug Checking over the last year, only 8 samples contain only fentanyl as the active drug. When people purchase and use fentanyl, they're using a complex and ever-changing mixture of substances, and this has implications for how we care for people who use drugs. Fentanyl adulterants. What is present in the fentanyl supply? Why is this important to know? And how does this affect our patients and the care they're provided? The data I'm going to show you today comes from the Toronto Drug Checking Service. This is a service in which people can submit either a small amount of an actual substance or used injection or smoking equipment. Clients will submit samples at a number of drop-off locations, most of them located within community health centers, which in Toronto are centers that include primary care as well as a number of wraparound services. The service provides lab testing and provides results to clients within 2 or 3 days, and users are given information on the composition of the submitted sample. Toronto Drug Testing also consolidates this data and produces reports on the composition of the illicit drug supply every 2 weeks. Sometimes they'll also issue alerts when they come across unusual findings and substances that pose increased risks to users. This program is funded by Health Canada's Substance Use and Addictions Program and a number of other health agencies. And unfortunately, with the closure of a number of supervised consumption sites, we're seeing much fewer samples being submitted for testing because these drug testing collection sites are often co-located in CHCs, and people are coming to use the supervised consumption sites and dropping off samples at the same time. This is an example of drug testing results. So this sample of fentanyl was submitted in May 2025. So one substance, fentanyl, is submitted, but it contains 8 different psychoactive substances. And what are the significance of these results for overdose risk, for complications from chronic daily use, for substance use treatment and withdrawal management? What do we need to know about these as people that are providing services? Why adulterate fentanyl? Of course, going back to the iron law of prohibition, potency equals profit. Fentanyl also has a really short half-life. We use it in procedural sedation because of this effect, but there are some drawbacks. Where heroin users may have used maybe 2 or 3 times a day commonly, it's not uncommon for someone using fentanyl to use 8 or 10 times a day in order to stay well or continue to get a euphoric effect. So adding other substances with longer half-lives or longer duration of effect can prolong the euphoric effect of fentanyl. And the other thing, is bulking agents. So both those with a psychoactive effect and inert substances can be added that help bulk up the supply and dilute the fentanyl to help maximize profit. Interestingly, the COVID-19 pandemic also brought on major shifts in the drug supply. Border closures affected supply routes. There was limitations in travel, which reduced people being able to smuggle substances across borders. Just like disruptions in supply chains for toilet paper, for fridges, there's also disruption in production of precursors, chemicals needed to produce drugs. There was closure in overseas manufacturing facilities because of social distancing. And what we saw was increased use during the pandemic, as well as increased costs and decreased quality. And we also had a decreased access to services because of closures and virtual care, limited capacity, etc. Okay. On to the results. This chart here is all of the substances found in fentanyl samples submitted to the Toronto Drug Checking Service in a one-year period from May 2024 to May 2025. I've included all substances found in more than 1% of samples, so the actual full list of different things found in the supply is actually quite a bit longer than this. The first substance here is caffeine. So 96% of fentanyl samples contained caffeine. The major driver for caffeine is simply as a bulking agent. Many people are familiar with pictures like this, which compare heroin and fentanyl and gives a good visual of how potent fentanyl is. With pure fentanyl making up only 3.4% of samples, caffeine's primarily used for dilution, making it easier to handle and dose fentanyl and bulking up the supply. The next substances we see are fentanyl analogs. High-potency opioids that have a similar chemical structure to fentanyl and mimic the effects of fentanyl. We can think of these as sort of cousin drugs of fentanyl, and we can see they've become very common in the supply, with 38% of samples containing fluorofentanyl. What we're seeing with increasing frequency is samples containing multiple high-potency opioids, so fentanyl itself plus other fentanyl analogs. In May 2025, almost half of samples contained 2 or more high-potency opioids. Fentanyl analogs are often more potent than fentanyl itself. Fluorofentanyl is twice as strong and present in more than a third of samples. Methylfentanyl-related drugs can be up to 10 times as strong as fentanyl itself and also present in about a third of the supply. I included carfentanil here, which is much more discussed in the media and is 100 times as strong as fentanyl, but at this point is actually quite rare, with only 4 samples containing carfentanil over the last year. So fentanyl itself is strong, but the adulterants added have driven the supply to be even more potent. What is the significance of these fentanyl analogs being present? When we think about how much medication it takes to treat someone's pain, provide sedation, or replace opioids for substance use disorder treatment, we're often underestimating the massive tolerance that people have. It's really profoundly high. The next group of substances are called nitazene opioids or nitazene opioids. And here we can see 4% of samples containing protodesnitazene. Although this is a low percentage overall over the last year, what we often see are spikes in the presence of nitazenes, so periods of time where nitazenes are present in over a quarter of samples over a number of weeks. And this has been covered a little bit in the media. There was a spike in nitazenes, and it was picked up by a number of news sources. Nitazene opioids are synthetic opioids that were developed in the 1950s but never used in human medicine, and they can be up to 25 times as potent as fentanyl itself. Being intermittently present in the supply presents a larger danger because users not usually exposed to nitazenes will have a higher overdose risk when it is encountered. We're also seeing nitazene opioids present in counterfeit pharmaceutical opioids like pressed pills of Dilaudid, Percocet, and oxycodone, and this is particularly risky as users will be expecting a low-potency pharmaceutical dose and a known dose, and could be more likely to be used by people who are opioid naive and perceive these pills as safer than illicit opioids. Here are some examples of counterfeit Dilaudid tablets containing 2 different nitazene opioids and how difficult it can be to differentiate between the counterfeits and the legitimate pharmaceutical tablets. Implications of fentanyl analogs, definitely an increased overdose risk. That intermittent presence means that it can be difficult to anticipate how strong your supply is going to be. These counterfeit pills, and again, very, very high tolerance because it's not only fentanyl that's driving how potent this is, but even stronger analogs being present. The next group of adulterants present in the supply are veterinary tranquilizers. These began to really be present in Ontario in the fentanyl supply in mid to late 2023. And in May 2025, 72% of fentanyl samples contained a veterinary tranquilizer. So we're seeing this really being in much of the supply and most people being exposed to it. This is sometimes referred to as tranq or tranq dope when the fentanyl contains xylazine or medetomidine. The effects of vet tranquilizers in the supply are excess sedation, with often prolonged decreased level of consciousness seen because the half-life is much longer than fentanyl itself. We see atypical and irreversible overdoses that don't respond to naloxone treatment, as these are not opioids. We see hypotension and bradycardia or slow heart rate, and sometimes we're seeing very low heart rates in people who are otherwise maintaining their oxygen saturation. We also see ongoing bradycardia and hypotension day to day in people who are using daily. And then, as Erin mentioned, wound formation, so characteristic wounds, which I'll talk about shortly. Xylazine was present in 32% of the supply in May. It's an alpha-2 agonist and a veterinary sedative. It's not an opioid, so there's no response to naloxone or opioid replacement therapies, and there's no research on high-dose daily use since this is not used in humans. So some of the effects of use are just not known. Because it's not used in humans, we know very little about what it means to be exposed regularly, and also the implications of withdrawal from xylazine. What we have seen is anxiety, irritability, restlessness, and then rebound hypertension, since it can be causing hypotension usually. The treatment of xylazine withdrawal is extremely experimental at this point, and is mostly symptom-driven. So this is not something that we know a lot about managing. Because it's an alpha agonist, it does cause peripheral vasoconstriction, which could be one of the reasons why it contributes to wounds. Characteristically, in the literature, we see this as initially appearing as blisters over a reddish purple discolored layer that then progresses into a thick layer of black eschar over a partial or full thickness ulcer. And there's an image here of what it can look like initially a few hours or days after injection, and then progressing to a necrotic wound. As Erin said, this is sort of the classic that we see in the literature. Sometimes we have clients coming in just with unknown or unusual skin presentations with no known injury, and sometimes we're wondering, could this be due to exposure to xylazine or not? So it cannot be clear. The interesting part is that these wounds are also seen distant from injection sites, and they're also seen in people who smoke only, who are snorting fentanyl. So it's not just the risk of injecting itself. There's something going on where this is going systemically and causing wounds elsewhere as well. The other vet tranquilizer we see is medetomidine, with 48% of the supply containing medetomidine in May 2025. Also an alpha-2 agonist, primarily used in veterinary medicine, but also used in sedation and general anesthesia in humans. And it's over 200 times more potent than xylazine. It causes sedation, bradycardia, muscle twitching, hypotension, and respiratory depression. And this muscle twitching side effect could also explain why we have been seeing some overdoses presenting with muscle rigidity, which is kind of unusual for opioids alone. The wound implications of medetomidine aren't really known. Because it's in the same drug class as xylazine, there's some thought that potentially it could cause the same sort of wounds, but it's not really being documented. Again, no response to naloxone or opioid replacement therapy because it's not an opioid, and the withdrawal syndrome is really unknown. Veterinary sedatives can cause this complicated overdose response, chronic hypotension and bradycardia, unknown withdrawal syndromes, and the chronic wound formation. The next group of substances seen in the supply are benzodiazepines. So we have bromazolam, desalkylgidazepam, and ethylbromazolam, nordiazepam. And they're a class of medications typically used for anxiety and managing seizures. However, what we see is the presence of these non-medical benzos or non-pharmaceutical benzos. So they're not ones typically used in medicine, hence why I have a lot of difficulty pronouncing at least half of them. These are quote-unquote designer benzos that have not been studied in humans, and because of this, little is known about the potency, the duration of effect of these benzos, and here we see about a third of samples containing bromazolam and a number of other non-medical benzos at lesser frequency. Non-pharmaceutical benzos have been found in 62% of opioid toxicity deaths in 2024. We also see non-medical benzos appearing in counterfeit pharmaceutical tablets like the counterfeit Xanax seen on the left. Benzo contamination has a number of implications. Benzos, especially in combination with opioids, can cause excess sedation and prolonged sedation. Again, we see atypical overdoses, which can't be fully reversed with naloxone. We see memory impairment both during acute intoxication, but also patients reporting ongoing deficits in memory, possibly due to that chronic exposure to benzos. We see benzodiazepine withdrawal, which can be severe and can lead to seizures with abrupt discontinuation. What we often hear touted in our training is that opioid withdrawal is uncomfortable, but it's not life-threatening, which in itself can be debated. But what's really important to recognize is that with benzos present in over a third of the supply, there's a risk for all chronic fentanyl users to suffer benzodiazepine withdrawal when tapering or discontinuing use. We've seen patients develop benzo withdrawal and suffer seizures with events like incarceration or hospitalization when fentanyl use is stopped abruptly. Benzo withdrawal symptoms include anxiety, irritability, nausea, vomiting, tremors, confusion, sleep disturbances, and when severe, hallucinations and seizures. And benzo withdrawal can take several days to develop because of the long duration of benzos. So symptoms might not show up for a number of days, but they can last 14 days or longer after stopping use. Despite how common benzo withdrawal is and how dangerous it can be, how difficult it is to stop using fentanyl with the added burden of benzo withdrawal, there's very little clinical guidance on how to manage it. And I always imagine this Spider-Man meme where different clinicians are all looking to each other for how we tackle this. Benzos have been a huge component of the fentanyl supply for over 4 years, and yet we're all still looking at each other for solutions and looking sort of for the first person who's going to start something new so that we can build on it. It's difficult to identify and differentiate benzo withdrawal. Clients often aren't aware that there are benzos in their supply, so they may be unaware that they're dependent on benzos. And some of the symptoms of benzo withdrawal are really similar to opioid withdrawal, like anxiety, nausea and vomiting, irritability. It can be difficult to differentiate and identify who could be at risk of the most severe outcomes. Classically, we're trained not to prescribe benzos to people using opioids because of the increased risk of overdose. So there's a lot of hesitancy to treat benzo withdrawal, especially within community settings where clients can't have ongoing monitoring. It's difficult to identify who needs intensive monitoring for seizure risk, and it's also very difficult to access inpatient withdrawal services that might be needed to safely withdraw from the fentanyl supply. It's also difficult to know what doses of benzo replacement to provide when we know little about the pharmaceutical properties or the potency of these benzos in the benzodope, and there's very little clinical guidance available for directing management. So what should we be taking away from all this information about the fentanyl supply? Our patients who use fentanyl can have extremely difficult experiences when faced with long emergency room visits or hospitalization, with really profound opioid tolerances and hesitancy to provide adequate doses of pharmaceutical opioids to manage withdrawal symptoms or treat pain. Our clients really can suffer greatly when in contact with healthcare services. Patients are also rarely being treated for benzo or veterinary sedative withdrawal. This is aggravated by poor inpatient access to addictions medicine providers who may not be available during the evening, so people may need to wait to the next day before they can access opioid replacement, or sometimes they're not available on weekends, for example, and some people may not be receiving what they need for a number of days if it is available. This is also aggravated by abstinence-only policies, which may discharge clients if they're found using, or if people are frequently leaving the floor in order to use. And what we see is patients declining to go to the hospital for urgent medical needs because they know they'll often face severe withdrawal and often discriminatory treatment from staff. Patients also leave the hospital due to inadequate care and suffer the consequences of untreated disease. We need to start looking at leaving against medical advice as patients really leaving due to inadequate medical care when they're forced to endure withdrawal syndromes in order to receive the care that they need. When talking to clients who are presenting to my office with things like a severe infection requiring IV antibiotics, even things like chest pain, clients are often really reluctant to go to the hospital to get treated. And it's not a matter of not understanding the severity or the urgency of what they're dealing with, but trying to face the experience that they're going to have going to the hospital. And I'm often in the position where I can't even provide adequate reassurance to say that this is going to be managed if you do go. So we see people just declining. The volatility of the drug supply means supervised consumption services are more important than ever, but sadly we're seeing political backlash against this healthcare service and the closure of many of our sites across the province. We've also seen the majority of safer opioid supply services close in the midst of politicization. Safer supply offers an alternative to the toxic drug supply for those who continue to use opioids and has been proven to decrease overdose risk and improve health outcomes. Harm reduction patient education for those using the toxic supply is also really important. Patients should be educated on the risks, signs, and symptoms of benzo withdrawal. I'm often talking to clients who are planning to reduce their use, that there is this risk, that there could be risks with abruptly discontinuing their use. We need to be talking about the presence of benzos, tranquilizers, and counterfeit pills in the supply, and the presence of xylazine and identifying xylazine-related wounds. As always, the importance of using accompanied by a friend or using an overdose prevention phone line when possible is very important. The continued availability of drug testing services is also extremely important, both for people using drugs and for clinicians and researchers to have information about the drug supply in order to provide quality treatment. If we don't know what we're actually treating when it comes to withdrawal management, we aren't able to treat it without these services and without this information source. There are also some point-of-care drug testing options, such as these xylazine testing strips that can give people immediate information on what might be in their supply. With changing composition of the drug supply and increasing potency, we're also seeing declines in the efficacy of our treatments for opioid use disorder. A 2025 study of OAT retention in Ontario found only 50% of people remain in treatment at 30 days and a quarter at 1 year after initiation. With profoundly high tolerances, it takes much higher doses of OAT to manage withdrawal symptoms and cravings, and also means it's a much longer time frame for medications to be increased and reach these higher doses for people to see an effect. What we also are not adequately managing is polysubstance dependency. People using the supply are not just opioid dependent, but possibly dependent on benzos or veterinary tranquilizers, and we need to innovate substance use treatments to manage more than just opioid withdrawal in this era. There's a much larger number of non-medical detox centers, not staffed with medical providers, than medically supervised facilities in Ontario. And unfortunately, we have very little regulation of detox or rehabilitation centers in our province. Withdrawing from benzos often requires medical management due to that risk of seizure and death if unmanaged, and the need to provide benzo replacement or anti-seizure medications under medical supervision. We need to make sure that when drug treatment services are expanded, that we're not just opening new non-medical detox centers, but opening centers which can meet this need and provide the care that our clients need. As of 2022, the average wait time for residential treatment in Ontario, which includes for non-medical treatment, was 100 days. So it's just quite unsafe for people who are trying to decrease or stop their fentanyl use. And the resources we have is just not meeting that need. For primary care, it's important to have a high index of suspicion for clients using adulterated fentanyl products. Considering adulterants with new and unusual presentations like unexplained hypotension and bradycardia, unusual wounds, reports of memory impairments, considering what people could be using and how that plays into the picture. Many adulterants are not detected by standard urine drug screening, and when new adulterants appear in the supply, it usually takes several years for our testing labs to sort of catch up and add that to our tests. You may need to encourage patients to submit their samples to drug testing to determine what they're using. This should be considered in hospital settings as well, which have the same limitations. So to conclude, I think it's important that healthcare providers are aware of how adulterants in the supply affect patient presentation, their risk, and treatment, and I hope that this was an informative presentation for that. Drug testing services are essential sources of information, and we need to advocate for their continued funding and expansion. We're not just facing merely an opioid crisis, but a toxic drug supply crisis, which requires a full spectrum of options and innovations in substance use care to meet the needs of our patients. This definitely includes harm reduction services and treatment options. And that's the end of my presentation.
Again, another wonderful presentation. So, Mish, thank you so much. That was really, boy, lots of information. And we certainly open up in the chat line for people to ask questions. You bring up a lot of really important points in terms of, how can we do a better job of managing something that is really not only complex, but it also has all of these hidden components, I think, around, and I know that Madison's going to be talking more about stigma as well, but, really thinking about how do we kind of parse out or, take apart some of the things that we are presented with as healthcare professionals, working with these populations who are not always evidently using drugs. So I wonder, it's a little kind of on the side of your topic, but, I wonder if you can comment on that as well. What are some of the, what are some of the tells, I guess, for healthcare professionals to be able to look at?
Yeah, I mean, that's hard to say. I often talk about how, with the decriminalization of cannabis, it was really quick to see how that changed the conversations that clients were having with us. I started to see clients come in and ask like, oh, like I use cannabis. Is this going to interact with what you're prescribing or with what I'm receiving? So decriminalization itself would certainly open up these conversations for people to feel more comfortable disclosing to their healthcare providers. But in lieu of that, it's really important that we are creating a safe environment, that we're indicating that we're a safe person to be disclosing to, so people can be having the conversations that they need to be having. In terms of tells, I mean, I don't want to sort of like add to the stigma as well, because it almost feels like a little bit like confirmation bias. Like, of course, you're going to see it if you see things that are obvious, like track marks. If you're seeing someone who's like leaving the floor frequently, that could be an indication. Certainly, like reluctance to talk to you, reluctance to remain in the emergency room or hospital. These are all sort of subtle tells. Um, yeah.
Yeah, I mean, I think it's just, one of the things that I certainly have seen over the years as a clinician, working with patients across all units in the hospital, is that, what you see in front of you doesn't necessarily, the assumptions that you make are not necessarily assumptions that are actually what's going on with that individual. So I was thinking about the little old ladies that we would have who would go into the DTs because they actually were quite heavy drinkers at home. But of course, this wasn't something that you anticipated or expected because they didn't appear, to be
Mm-hmm.
in that milieu. So, I mean, I think certainly there is kind of, again, an assumption of people who are drug users will appear like this. And
Right.
what I think is to recognize that that's not necessarily the case. Um, so Madison makes a comment here. I also think it can be handy to bring it up as a provider, providing information without accompanying assumption, regardless of suspicion, can go a long way.
Yeah, it's also not expecting people to feel safe immediately to disclose, and having a lot of compassion and understanding for that, because people are very used to having negative experiences when they do disclose. So it can take time, demonstrating that openness, asking those questions, to demonstrate safety before someone is going to disclose that to you. And again, that's that relationship building component.
And perhaps one of the important things too is in terms of, people presenting in emergency rooms or people presenting in medical clinics, for example, is that we, like you were saying about I liked your comment about, well, I didn't like, but I agree with your comment about, leaving AMA, and having worked for many years in a hospital. I mean, this is just common sort of what we see, but the reality is exactly what you're saying. So, part of it is really changing changing the paradigm in what we do in those kinds of settings where people are presenting, and how do we deal with it? So yeah.
Yeah, that's I feel like that's my like bone to pick. That's my like real point of frustration. Because often I'll read discharge summaries for clients, and it'll say things like, the client says that they're going to leave because of their withdrawal symptoms. And then it says they left against medical advice. And I'm like, to me, it's so clear here that there was an intervention that could be offered that just wasn't. And that's why they left. And it's not against medical advice, because you can talk to the clients and they understand the gravity of the medical situation that they're dealing with. They understand the treatment that they need. They understand the importance. It's just that the conditions that they're being put through are intolerable and a barrier to getting the care that they need.
Right. Because, again, if someone had diabetes, for example, and presented to say, I have diabetes and I need my insulin and I don't have it here, what would happen in that situation, in comparison? Yeah.
Exactly. Hmm.
Yeah. So, I'm wondering, it's that adapting the way we screen, the way we assess, and the way we follow up that, is something else. And one of the, I wanted, I did want to also ask you about, in terms of the rescue types of treatments that are available, you know, the fact that a lot of the drugs that people are using are combination drugs. So can you speak a little bit about, you know, Naxalone and like, you know, what are some of the things that healthcare professionals and harm reduction workers should be aware of when they're kind of in situations where maybe someone isn't responding?
For sure. What we also need to tell clients, and what I try and reinforce too, is like, yes, these specific substances won't be reversed by naloxone, but reversing the opioid component of what they're using can still improve the overdose, can reverse at least that component of the overdose. So it's still really important to use naloxone when it's indicated. That said, this is also why the supervised consumption sites are so important, is because they have a range of interventions to be used. And I'm always telling people, like, you'd be surprised how infrequently naloxone is actually used, because a lot of things can just be managed with oxygen, with positioning, with stimulation, with just prolonged monitoring. But it's so expensive. Expensive, inefficient, inhumane, to be having to call 911 and have people managed in an emergency room, when they could be managed by people in the community quite easily at a supervised consumption site. But what we see with the naloxone and with these overdoses is, you know, if we see someone who's very sedated, who's not really responsive after using, with fentanyl, we're often, okay, the respiratory rate's going to be depressed, the oxygen is going to be depressed, but then you'll have someone who's like almost unresponsive, but their oxygen is fine and their respiratory rate is fine. So what's going on in that picture? I start thinking about, okay, this is not the picture of an opioid overdose. This is something else. These are these contaminants that are causing just really, really severe sedation while the other vital signs are maintained. Or you'll give naloxone and the oxygen comes back up, but then they're still very, very sedated. And this is also, it can cause issues with services, because people may take a lot longer to recover, taking a lot longer time in the supervised consumption site, or even like in my office, where they're stable, but it's just going to take a lot of time before they're able to be up and moving. Yeah, so those are some aspects of the use of naloxone and what those overdoses can look like.
Because it's certainly promoted, you know, I think without the recognition of the contaminant issue,
Mm-hmm.
and perhaps be more of a challenge because people are not aware that there are a number of contaminants that are in these drugs.
Yeah, and that if you are having a drug toxicity event, it may take a lot more than just naloxone to intervene. We don't have sort of the magic key to reversing all these overdoses anymore in this setting.
Right, right. Which is perhaps also a way of identifying the fact that, you know, that's where the safe injection sites are really beneficial. Yeah.
Very, very beneficial, and also we could be educating people more on things like airway management, on rescue breathing and those aspects of overdose management. You know, people can be very comfortable with administering naloxone, but may not be comfortable with those other interventions that will really help. I personally have an ambu bag in my car, but that's just me.
But you're right. And I mean, from an education point of view, and I mean, I look at things from that perspective, you know, I think I can see a lot of opportunity then for really looking at, you know, how can we do a better job with this? And I think, you know, just to give a plug for our upcoming harm reduction worker certificate program that we're in the process of developing with you folks and others for our offerings in the fall. These are the kinds of things that we need to be looking at, because the landscape is definitely changing and has changed. So yeah, for sure. We have a couple of comments here. Hospital policy also creates inequitable barriers. So London Health Sciences Centre, where I actually used to work, has a policy where if a patient is away from their bed for a certain period of time, they are deemed PDD. And I'm not exactly, I'm not familiar with the term, but they're basically, they end up giving up their bed, even though they may be addressing responsibilities outside their admissions with the full intention of returning, or simply having a cigarette outside, but taking their time due to ambulatory barriers, plus the fact that in pretty well every hospital, the expectation is that if you smoke, that you have to go a significant distance from the entrances. So yeah, I can understand that that's an issue.
I think that's patient-directed discharge.
Patient-directed discharge. Oh, okay. All right. Not a term people were using when I was working in the hospital. Erin is saying use the face shield. Use the face shield.
Yeah, the naloxone kits also come with a face shield, like a disposable face shield for providing rescue breathing.
Right, right. I have another, we have a couple of minutes left. I have another couple of questions to ask you, while I have you here, that I wanted to ask you about, one about ketamine. Can you talk a little bit, because, ketamine is certainly something that seems to be on the rise. Certainly when you see the media, this is something that is out there. Can you talk a little bit about ketamine and ketamine use?
Yeah. So ketamine is somewhat hard to place in like what kind of drug it is. It's a dissociative anesthetic, but it also has like some psychedelic properties. In like smaller doses, it can sort of cause the effect of sort of feeling a little bit drunk or a little bit out of it, and in larger doses can cause like full dissociative experiences. Ketamine, we've also seen a little bit of contamination. So we've seen some samples that are coming back with non-medical benzos in them. Really rare to have, as much as it's talked about, it's actually quite rare to have fentanyl contamination in other drugs, at least in Toronto. So yeah, some of the effects with chronic use, people can get issues with bladder dysfunction, and certainly, it does carry the risk, especially when mixed with alcohol or other sedatives, of causing toxicity as well.
Yeah. Yeah, great. So Erin has a question here. Can you speak a bit to the Compassion Club model for folks who may not be familiar?
Yeah, for sure. There's a number of different models that sort of fit under Compassion Club, so I'm hoping I'll do it justice. But generally, when we talk about safe supply or safer supply, we're talking about a medicalized model. So where people who are able to prescribe medications, nurse practitioners, doctors, prescribe pharmaceutical opioids for people to use. And there's a lot of ways in which that's limited, difficult to access, certainly funding issues. And then that it's not able to offer, most of the time, able to offer fentanyl or fentanyl equivalent products. So there is the challenge, again, of people having very, very high tolerances, and then trying to provide sort of low potency pharmaceutical opioids to try and replace that can be really challenging or not effective for a lot of people. So there are also non-medical models, which are established by communities of people who use drugs, who purchase drugs. Like they could be purchasing fentanyl, whether that's often it's from like online black markets, getting that tested so that it's of a known potency, that they know what the components of it are, usually trying to source something that doesn't have adulterants added to it. And then in this Compassion Club model, there being a number of members who can then access that supply. So it's creating a safer supply of a drug on a community-based level to provide something that's safer. If people are interested in that, I definitely check out DULF, DULF, who's been doing this in BC and have done research on their project and shown no deaths amongst their Compassion Club members. But unfortunately, that is also currently going through our court system where they've been prosecuted for trafficking.
Right. Well, and these are the kinds of things the legal system needs to catch up often, and that can be kind of difficult to do as well. Yeah. So if there are looking to see, and we will these are the kinds of resources that we will make available as well, so that people can take a look at them. Great presentation, really interesting. And I think one of the real highlights in terms of recognizing that these drugs are not singular anymore. It's not the sort of that you're actually getting fentanyl. So when people think that they're getting one thing, they may not be. I just have one last question for you. That has to do with the counterfeit aspect of drugs. Is there any, when you showed the images of the different tablets, for example, it's really hard to tell them apart from just, from visually looking. Are there any things that you would suggest as, again, for healthcare providers, if someone is showing them their tablets, whatever, that you can really kind of say, oh, you know what, let's take a closer look at this? Are there any tips around that?
I would say like the counterfeits can be so perfect. My biggest message would be accessing drug testing where possible. So drug testing, even for purchasing pharmaceuticals from an illicit supply. And then when people are using things that they haven't received from their own prescription, making sure that they're using a small amount of it first, so doing a test dose of that, making sure they're using accompanied at a supervised consumption site if possible. And then we also have things like the NORS overdose prevention line. So it's a phone line that people can call or text when they're using a substance, and they will accompany the person virtually. And if they do become unresponsive, they'll contact 911, or they'll contact like a contact person that's being provided by the person using. So sometimes people will even be like, well, my roommate's home, I don't really want to tell them that I'm using, but I'll tell the phone line, hey, my roommate's home, here's the phone number. So if anything happens, they would call the roommate and say, like, the person in the other room is overdosing, like, please attend to them. So there's some creative options for people when they're not able to access things like supervised consumption.
So maybe you can put that in.
Yeah, for sure.
If you don't mind, that would be really great. This is wonderful. I think this is really, helping to clear up misconceptions, and also a way for us to really think about what are some of the ways that we can do a better job here as well. So, really, and I think that Madison's presentation is going to be really amazing as a sort of a, the kind of look at how do we, okay, now what do we do kind of thing. So, but so thank you so much for this presentation. This was excellent. And we're going to start up again for our third presentation today, and I want to welcome you all back. We have approximately 50 people in our symposium today, so that's wonderful to see everyone here from all across the country as well as into the United States. So welcome to our colleagues who are joining us from the US as well. So just to get started with our third presentation, so Madison Joyce is going to be our presenter. And Madison is going to be talking about stigma to solidarity, harm reduction across the continuum of care. And Madison is a registered nurse who is a Master's of Nursing student in the nurse practitioner stream. She's worked in harm reduction-based primary care, outreach, and substance use care. Her work is grounded in dismantling barriers to care for marginalized and traumatized populations. So excellent presenter, I think, for this particular topic. So Madison, if you want to get your slides up, we will get started, and then we'll have time again for the opportunity for people to ask questions through the chat line as well. So welcome, Madison.
Thank you so much, Rosemary. I just want to confirm that you can't see my presenter mode. Is that correct?
Yeah, you're great.
Okay, awesome. So, hey folks, it's hard to follow up those presentations, but here I go. So my name is Madison Joyce, and I'm a registered nurse, yes, with several years of experience in harm reduction across a variety of settings. And relatedly, I am here to talk to you about the integration of harm reduction across the continuum of care. So for a little about me, I started my nursing career in early 2020, initially in shelters and outreach settings before moving into primary care and substance use care settings. When I returned to school to pursue becoming a nurse practitioner, I couldn't juggle the 9 to 5, so I transitioned to a hospital role as well as taking on a casual role in a supervised consumption site. And across all of those settings, I was able to draw on my harm reduction experience from my youth, where I was embedded in sexual health related harm reduction, particularly with queer youth and sex workers. So harm reduction is undoubtedly something that comes up day to day in my practice. I also just want to acknowledge that I too am located on the traditional unceded territories of the Anishinaabe, Chippewa, the Haudenosaunee, the Wendat peoples, in addition to the Mississaugas of the Credit. This territory is governed by the Dish with One Spoon Wampum, an agreement to share and care for the land and its resources, disrespected and ultimately desecrated by my settler ancestors. So I carry this awareness with me and commit to reparations for the longstanding issues caused by these betrayals. On the docket for today, I and Erin chatted with you all about wound care, as well as an immense amount of things that I may or may not cover. We'll see. And Mish gave you some background regarding the contaminated drug supply with handy tips and ways to apply it. To wrap up our presentations for today and leave you thinking as you leave, I'm going to cover some theoretical pieces you're most likely already at least a little familiar with. Then we'll arm ourselves with a toolkit that will help us face a variety of challenges across specific health and social care settings. And then we'll end out with some final thoughts and takeaways to challenge our own and others' unconscious biases before we wrap up for the day. And I will warn you all ahead of time that I try to be a little too comprehensive. But due to time constraints, have cut some pieces out while trying to make it all fit. I'm also trying to keep it fresh so that you aren't just hearing something that you've heard multiple times before. If I leave something out that seems obvious, that might be why, but I'm also very down to hear about it, engage with it afterwards. So the healthcare system, like many, is particularly difficult to distill, especially when you work within it. It's got a lot of moving parts and it's changing from day to day, and the demographic that we serve is essentially everyone. So while there's a lot more to it than this, both positive and negative, I think we can all agree that our system is resource deprived. Some of our hospitals might have beautiful artworks and atriums and gardens and fancy equipment and brand new infrastructure, but many Canadians are without care. Wait times are long, and there are nowhere near enough care providers to meet the needs of our population. We also have a really fractured system. It's not continuous, siloed into specialty areas. And don't get me wrong, I don't want the person operating on my eye to be the same person who does my counseling, but I would love for them to be able to take my anxiety into account. We have to see people in different places to get our care needs met, and we just kind of have to hope that they're all communicating with each other adequately. It's also highly structured with limited flexibility, particularly as it relates to time. We as providers understand that this is to be able to meet the needs of as many people as we can, and it's sort of easy for us to say you snooze, you lose when someone arrives 15 minutes late for a 15-minute appointment and the rest of the day is booked solid. But for some people, that can actually create a system that's totally inaccessible. And I do think we know that, but just reiterating. I also want to touch on the terms evidence-based and patient-centered for a moment, just before I go on too long on this one slide. When we talk about evidence, what we're doing is placing inherent value on empirical evidence, which is fantastic. It's derived through study, academia, it's rigorous, it's trustworthy. But we're not placing that value on experiential and personal knowledge. So where Erin talked about patient preferences as being super important to care, there's a really good reason for that, and we'll talk a little bit more about that as well. That also doesn't even begin to mention the lack of value for traditional and cultural bodies of knowledge. I also want to say further, while we can look at a term like patient-centered as incredibly positive, and it is, it also sort of serves to highlight the many ways in which our healthcare system places responsibility on the individual, with providers directing care at a patient rather than working with them and their formal or informal care teams. Also, importantly, it disregards the value of the community, whether it be family, friends, care providers, or for that matter, people owe money to. That could be an important part of their care process. So this individualistic lens puts emphasis on adherence. And when we talk a big game about collaboration and meeting people where they're at, and I will talk a big game about that, but we also assume that their ultimate goals and meaning of health are the same as ours, and that once their goals align, surely they'll adhere to the plan that our evidence tells us is the best one. So to top all that off, the system is very, very bureaucratic. Lots of checks and balances in place in the forms of protocols and documentation, ostensibly to support the safety of patients and providers, but in practice can take up a lot of time and energy. This doesn't negate their value. They're super important, but it is something that we have to carry with us and acknowledge. So these elements all contribute to structural violence, which is a term defined as harm inflicted by social structures or institutions that prevent them from meeting their basic needs or rights. What I mean by that is that these structural elements in many ways uphold forms of systemic discrimination that are baked in. I'm not going to dive too deeply into these concepts, as I think we have all heard them many a time, but I also don't want to start this presentation off too dishearteningly. It is incredibly, incredibly important to recognize that the system was built by people in power to support people in power, and in many ways perpetuates social divides through racism, classism, sexism, ableism, transphobia, homophobia, many others. And I think a lot of the time we feel powerless to tackle these issues, that they're too big. So sometimes we can get a little bit defensive when it's pointed out that we're complicit, but we're not powerless to create change or at least positive experiences from within. In particular, and definitely more visibly, the system facilitates stigma, judgment, and stereotyping, which we've talked a lot about. This can be relating to things people do and don't have control over, as well as things that we perceive people to be in control of, whether or not that's the case. So these come through in action and inaction words and facial expressions, or sometimes just a lack of patience, positivity, or second chances. And I want to pause for a second, because I think it's fairly easy for most of us to think of times that we've witnessed stigma and stereotypes in action, though harder to identify how we may personally enact them. If you can, take a second to reflect and see if you can think of a time yourself. And to help, I'll just say that in my experience, these come out most often when care providers feel like someone gave them a reason to fall back on stereotypes that we don't like to personally think we believe in. An example might be someone growing restless in a waiting room as you wait to see a specialist. And as they start to pace around, maybe they swear under their breath. And I don't like to admit it, but yeah, the thought better give him some space enters into my brain. And I might even try to quiet the part of my brain that suspects maybe there's stimulants on board, and that's contributing somehow to what will surely become an outburst, which will surely put people in danger. And this is a rabbit hole that we've been socialized to go down into. So I'm trying not to feel super, super awful and super vulnerable saying that to you here, but rather to offer you space to allow yourself to reflect authentically and vulnerably, and to not act on those thoughts, but to enter into your care spaces from a place of compassion and empathy. These things can result in increased criminalization, whether that be in indulging in these stereotypes and a self-fulfilling prophecy happens where staff involve the police, or it could be in the form of the threat of justice involvement as police frequent emergency department waiting rooms for pre-custodial clearances or psychiatric accompaniments. And that can create a real or potential threat for individuals with or without justice involvement for various reasons. I also want to bring up intergenerational trauma, which can refer to multiple things, one of which being like the compounding impacts of traumas from one generation to another, and the other being like the epigenetic expression of trauma, where traumatic experiences of our ancestors alter the expression of our DNA, which makes subsequent generations more susceptible to mental and physical illnesses. For many people, including Indigenous peoples and other racialized populations, a number of these traumas have occurred within the walls of our healthcare systems. Whether or not this is the case for an individual, many traumas in general occur in healthcare settings, and subjecting oneself to repeated exposure to the threat of that happening is incredibly difficult, to say the least. I also finally want to touch on cultural and language barriers within these settings. So while these are not the focus of the presentation, there is significant overlap, as I'm sure we all know. But the consequences of this systematized discrimination and marginalization come in the form of delayed, incomplete, and inadequate care for acute and chronic conditions, increased rates of overdose and overdose mortality, increased rates and less treatment of bloodborne illnesses like HIV and hepatitis C, systemic infections like endocarditis and osteomyelitis. It also resulted in further criminalization and institutionalization, as well as, unsurprisingly, increased healthcare costs. Erin talked a lot about it. Mish talked a lot about it. An infected wound that could have been resolved with a course of oral antibiotics if a person had been able to access primary care could snowball into a case of osteomyelitis requiring multiple weeks of antibiotics. That person could attend an emergency department and wait hours to see someone going into withdrawal. Then in their agony, the providers might not catch the wound under their pants and might be incredibly burnt out and label that person drug-seeking. The person might curse at them and then be upset and leave the emergency department, and that infection could snowball into a need for an amputation. Just everything adds up, you know what I mean? All of this just reinforces the perpetuation of this cycle of distrust, trauma, and violence within our healthcare settings. So to combat these things, I want to talk to you a little bit about like a toolkit that we kind of keep on us already, but we don't always remember when or how to use the tools. And there are a ton more things that we all bring to our careers individually and as a group of providers, but I only have so much time to chat with you, so I want to focus on 4 big sections of concepts that go well with each other, and they are this self-awareness, self-reflection, and self-care, curiosity, compassion, and empathy, honesty, accountability, and forgiveness, and language communication and cultural safety. So to start with, what do I mean when I say self-awareness and self-reflection? Well, I think most of us were either taught to or learned to participate in some level of self-reflection. Life experience, academic settings, wherever. For many of us who had the privilege of going to school, we were probably taught to identify our biases, writing reflexive journal entries and positionality statements for academic papers. We've been told to debrief our challenges with our friends, our mentors, our therapists. We've mostly had it drilled into us that through socialization, we are inherently biased. Sorry about the cat, but that we can challenge our biases and unlearn these things. And I think probably for most of us sitting here, we don't like to think of ourselves as holding up these systems that perpetuate the problems that many of them exist to address. We can all probably list our privileges and see that as nurses, social workers, peer workers, physicians, PSWs, people who get paid to contribute to the care of others, we have power in those care relationships. It's relatively easy to acknowledge those things in theory, but more difficult to consistently show up with them in practice, and the priorities we choose to uphold all too often aren't reflective of these. So I want to just bring some attention to a particular cognitive bias, which is the cognitive bias termed fundamental attribution error. I don't remember all of the cognitive biases I was taught, but this one sticks with me. What it refers to is the fact that we are more likely to attribute our own mistakes and decisions to context, rationalizing them and making them acceptable, excusing them, while we're more likely to attribute others' mistakes, errors, and decisions as character flaws. If I messed up someone's pronouns, it's because I didn't get any sleep and it was a slip of the tongue and somebody else used the wrong pronouns. But that person messed them up because they're transphobic. That's what it's one of those things. Does that make sense? So I want to acknowledge that what we were taught in school takes a long time, and I'm not suggesting that we take time to journal and debrief between every challenging patient encounter and weigh out the biases that might be contributing before we make a decision. I know that sometimes things are life and death, and I want to talk about how we can try to make things happen in the amount of time that we have. So there's lots of things we can do before, during, and after. I just want to highlight some elements of the therapeutic method of acceptance and commitment therapy, which I find to be helpful. I'm not a therapist, but I will suggest that if an interaction with a patient or client made you feel a feeling that wasn't entirely positive, whether it's guilt or anger or shame, or just, I hope that doesn't happen again, I do encourage you to contemplate it. What could you try differently next time? I'm not asking you to have all the answers, but if there's something that could potentially make something a little bit better, give it a try. If you keep doing this, something will be better, and those things add up. Like Erin said, in the moment, I really, really, really encourage you to be present and be intentional with your presence. Autopilot, very real, convenient, efficient to go through the motions. But while it may take up some capacity to be mindfully present with our patients, it doesn't actually take significantly longer and can make a world of a difference if and when you have the capacity to think for a beat and also just be there with the person, be real. Finally, I encourage you to identify the core values that brought you to healthcare and social services. Hold these core values and act on them whenever and wherever possible, because there's a reason you're in this field. And I don't want to turn into a motivational speaker here or like be preachy, but I like to always have a value that I'm working on right now. This is especially true when I'm feeling particularly unmotivated or burnt out or pushed to my limits, which right now might be all the time. So right now I'm working on courage, which was not one of my core values, but it is one of my least exercised values. All of that is to say that if I'm feeling challenged by or disgruntled by a particular situation or client, I'll take like a deep breath and remind myself to practice empathy or practice courage or practice creativity. And honestly, literally whatever value I remind myself of, it helps me to make better decisions in a given interaction. So I also want to talk a little bit about curiosity, compassion, and empathy now that I feel sufficiently out of my element. We've had these things since we were little children. And I think we all have a good understanding of compassion and empathy, but I do want to highlight why I group them together with curiosity. So for me, curiosity is a desire to learn or understand something, suspending your judgment to figure it out. And our jobs involve a lot of questions. A lot of the time we're asking those questions to fill out a form that will dictate the care that we will or won't provide an individual. And people know that, and there's a degree to which some of those questions can come across as like interrogation. On the other hand, there's a degree to which we as providers avoid asking questions, whether it's because we don't want to interrogate people or we don't want to look like we don't know something or because we don't think it will change the treatment plan. And while these are fair and understandable and potentially even time-saving, you got to build rapport. It's such an important thing. It also supports the principles of trauma-informed care by establishing a sense of safety, demonstrating transparency and humility, and empowers them, inching towards like a leveling of the interaction that supports collaboration and trust going forwards. By exchanging knowledge through the interaction, you paint the picture of what's going on together and engaging in a sort of shared meaning making. So some specific strategies that I like to incorporate are ask, don't assume, and ask, don't tell, where the first one simply means that if you don't know something, ask about it, whether it's measurements of drugs or what different equipment is used for, terminology. It may be helpful to explain why you're asking also, like whether it's that you've heard people say that but don't know what it means, or that XYZ is how it will change their healthcare. And either way, it demonstrates that you're coming at it from a non-judgmental perspective. When you don't know something, it also doesn't take away your power, but it does provide transparency for people who have been messed around with by people who pretend that they fully know and understand their experiences, or by people who feel that their experiences aren't important. By ask, don't tell, I'm referring to care acts for the most part. Ask if you could take their blood now. Can I get your hand into a fist? Do you need anything before I do your wound care? And I also want to emphasize that regardless of these strategies, I don't mean don't tell them what you're doing. Explaining what you do while you do is super important. And I also don't mean that no one is ever going to say no to your requests. People are going to say no sometimes. You know what that is? That is a great opportunity to do some reflection. There's some time there. When someone says no, we can jump too easily to assuming that they don't want the thing at all or ever, and a ton of context pieces might be at play that we don't see. They might be in the middle of a conversation. They might be in pain or anxious. They might not have a clue what you're talking about, and so they say no. It's a great opportunity to inquire. We can get hung up on getting all of our tasks done in the amount of time that we have allotted, and I really, really do get that. So when for you, you're just tired of hearing the word no, offering choices can go a long way. Blood work or wound care first may not feel like a useful question to ask, but sometimes having some influence over what's happening to your body can really make a difference. I also finally want to offer this thing that I call the if ideal exercise, which can be useful if what you want to tell someone isn't like an askable thing, and can really, really be used in a variety of circumstances. So I want to take an example of somebody who's picking at their wounds. I know that you really want to say, don't pick at your wound. Don't pick at your wound. It could introduce bacteria. It could get infected. It's already infected, whatever it is. The fact is that a lot of the time, people might still pick their wound. I know I do. People aren't always going to do exactly what they're told, but behavioral modifications are a lot easier than elimination, which is honestly a huge part of applied harm reduction. And in this case, we could say, ideally, don't pick your wound, but if you're going to, wash your hands first. And there's like a cascade of intermediaries that can go in between. But I just wanted to bring that as a potential for you. So going back to those principles of trauma-informed care, I want to talk a little bit more about transparency and trust building, respecting consent, empowering people, building rapport. The information that we provide people is incredibly important. Something that we can't underestimate is the importance of this honesty and accountability, especially if we mess up or something isn't going to go the way that they want it to. If I told you that I'd come to you in an encampment on a Tuesday and I'm at home with a stomach bug and the person I asked to go in my stead can't find you, it might be tempting for me to say, well, I sent so-and-so and you weren't there. I'm not going to. I'm going to tell them honestly that I was sick, and then I'll establish a plan with them just in case there is a next time. I might, maybe there was a code blue and you forgot to get their PRN pain medication, but you're so sorry, you'll grab it now. Those things give transparency, vulnerability, and over time build into trust almost as much as following through can. Similarly, when people ask what the plan is, if we can anticipate bumps in the road or pain or something like that, we should articulate that clearly and plainly, not beat around the bush. Often that builds up to be more than it is. But if you're giving someone a shot of penicillin in their gluteal muscle, telling them that it's not going to hurt or that it's only going to hurt as much as a flu shot might not be helpful towards building trust when it hurts a lot. It also really messes up the informed consent process. I'll just say that. There is courage and power in honesty, accountability, and apology, exponentially so when accountability hasn't done anything for you in your life. So now I'm talking about patient perspective. With that said, when someone escalates in the waiting room of the clinic, then misses their next 2 appointments and comes back with their head down because they're embarrassed that they threw a coffee cup at a wall, that's huge. Whether or not it's an apology, that's huge, okay? And an apology is even huger. Approaching conflicts with clients as you would with a coworker, manager, friend, family member is honestly one of the biggest things that I do. And I mean that across all settings and demographics. The resolution of a conflict nearly never depends on one person doing all of the work. When we learn about conflict resolution styles or methods, we learn of negotiation, collaboration, compromise. We also learn of passive and authoritative conflict resolution styles. And putting all of the onus on the patient ends up being some sort of a mutation of the two extremes of the continuum that are known to be the least effective. So to that end, please follow through with what you tell people when you can. Be courageous in apologizing when you can't, and accept apologies when you receive them. Opening yourself up to accountability creates trust, and then working with people to collaborate to resolve conflict and prevent future incidents, that's what sets the basis for that. So on the topics of language, communication, and cultural safety, much of this very straightforward following the last items. I just want to touch on jargon and lingo. When I talk about that, I mean language that is specific to a context, career path, or setting. Some examples, medical jargon. That one's very clear, but we also might look at things like acronyms that we use on the regular. Someone might not know that an SCS is a supervised consumption site. Someone might not know what septic means, and it might not mean much to them without further contextualizing. When someone already doesn't trust the system, it's hard to trust that someone in power is well-meaning when they don't offer meaning. On the flip side, I use lingo to mean essentially the same thing, but with less of what linguists refer to as prestige or desirability. So medical and social services use jargon, and that jargon conveys power, while we're more likely to interpret slang and lingo related to substance use culture, for instance, as indicators of lower social status. A consequence of that is that people within these systems don't feel a need to learn the lingo used because we don't perceive it as being of value to our work. And what this does is, like, it just massively deepens the divide. Terms like withdrawal versus dope sick or sick may feel straightforward enough, but one lesson that I learned more recently than I care to admit is that not all folks who are using benzos know they're using benzos. And I don't mean that as like a contaminant in the fence supply, as Mish was talking about, but rather that they get sleeping pills or PAMs or simply Valium and like categorically aren't familiar with those as being benzos. In practice, this might mean that a no or not intentionally on an assessment is false, and assumptions can be made that the patient is lying when really that's not what happened there. So coupled with language barriers, these issues become compounded and just really, truly brutal. So to sort of fight back on this, I like the "what do you mean" question. That just goes back to asking, not assuming. We all use the teach back in various circumstances, whether it's like getting people to tell us back the appointment that we just booked for them, or talking about how how a medication is used. Oops, sorry, folks. There we go. I also just want to touch very briefly on style shifting and language mirroring and when those are and are not appropriate. So when I say style shifting, what I'm talking about is if you're familiar with the language that you're using the vocabulary that they use, as long as it doesn't perpetuate the stereotypes. So this doesn't mean calling someone an addict because they call themselves an addict, but it may be to inquire about how many points of a substance they're using daily, if they're shooting it or smoking it, how long afterwards before they're sick. And if you aren't comfortable with the specific terminology, there's something to be said for just speaking more casually in a way that, like, it conveys a leveling of power. If someone swears, maybe you feel comfortable swearing with them. It can really level out a relationship. I don't know. That's just something I do. I'll also just touch on interpreters, advocates, and peers. Get to know them, communicate with them. The navigators that are available to you, if they're available to you, please use those resources. I will also say that metaphors can be a powerful tool for explaining concepts that are jargon heavy, and person-first language is something that I think we're all familiar with at this point. Let me know if you're not. Apologies. Talking a lot. So finally, I just want to reiterate the importances of self-reflection and self-awareness, and then bring in self-care. The impact of burnout on our capacity to engage empathetically is huge and intense and very, very real, and none of us are bad people because of that. Or at least not just because of that. On top of that, in our workplaces and working with populations who use drugs can result in significant first and secondhand trauma. We aren't always mentally prepared to hear the stories that our patients share, and we're pretty much never prepared to personally hear of something bad happening to them. Building relationships that end in grief and loss, and addressing the manifold griefs and losses of our patients can take a huge toll. And on the other hand, it can be incredibly powerful to acknowledge the effects that these traumas have on you when it's appropriate. So I want to touch a little bit on self-disclosure, and I don't mean in ways that detract from the therapeutic relationship, but I think we have all been taught not to self-disclose, and that can be harmful in some ways. So I don't want you to, like, if you're triggered by what a client says, I don't want you to tell them that, but the acknowledgement that you too have experienced the deaths of loved ones, people you care about deeply in the context of a toxic drug crisis, can build shared understanding and strengthen a relationship. On the other hand, if something's triggering or a code response is really hard, really, really do debrief with your coworkers, friends, mentors, therapists. They're there it's a really good way to dissipate the challenging feelings and address them both short and long term. Having the knowledge and awareness of your own traumas and triggers, safety planning around them is really, really important. And yeah, journaling, work-life balance, whatever supports you in your self-care experience outside of work can and should take priority, especially when your cup isn't full, because you can't pour from an empty cup. When something's outside of your capacity or takes up more time than you have allotted, engaging your professional team or interprofessional team to support the patient, and sometimes yourself, can go a very long way. So, in this final part, I'm going to give you some specific ways to apply these harm reduction supporting concepts and tools within specific settings across the healthcare continuum, and identify some examples of how barriers manifest across those settings, reduce, address, and mitigate those barriers, and ways that people and the ways that people and the ways that they impact people who use drugs and vulnerable populations more generally speaking. So, harm reduction, not just supervised consumption sites, eh? Huh? There are countless places that people practice healthcare, and honestly, I could talk for hours about how to integrate the principles into all of the specific settings. I want to touch specifically on the ones that I think employ the most of us and the ones that our patients are attending most frequently. I am going to try to keep things as brief as possible to avoid running out of time and also to avoid boring you about settings that you're not in. But I do want you to feel free to take a screenshot, feel free to take a picture, feel free to come back to this later, feel free to share with people who you know who might benefit from the settings that you're not personally involved in. Before that, I just want to say across all settings, here are some ways that we can integrate harm reduction concepts, or at least like harm reduction supporting concepts. So big time emphasizing rapport building. Trust, comfort within the therapeutic relationship is so key. Also acknowledging that sometimes people are in survival mode and meeting basic needs of food, water, and shelter are their priorities. If we can try to meet some of those, sometimes that's super helpful. Working with people in withdrawal and working with people who are intoxicated can also be tricky. Having some personal and patient-specific plans to provide care under these circumstances is necessary. Addressing withdrawal makes a huge world of a difference. I know that's been talked about. I just want to say it one more time. Maybe a few more times, we'll see. But having a way to address that, to uncover what is underlying, is super necessary. I'll also say having backup plans if folks are too intoxicated at a moment in time to engage with care right now, incredibly important across all settings. With also in all settings, establishing goals and collaborating with them, establish their goals and collaborate with them on how to achieve them is key. You can contribute to the information and ideas without placing your goals ahead of theirs. Please integrate those concepts of conflict resolution, de-escalation, and really the how to move on after conflict is very key. I want to say that if you feel unsafe, but are at least theoretically aware that your safety wasn't truly threatened, on a personal level, identify what would make you feel safe moving on and ask for that without placing responsibility on somebody. There's something to be said for anticipating potential consequences, and that goes back to the contributing information without placing your goals ahead of theirs. Like, anticipate that something might happen and ask about that and establish a plan together for that. Be flexible in your timing, offering choices, very useful. And I also just want to say, when I make this point of interprofessional team with role clarity, I mean that knowing who can help with what is super, super key, and then incorporating all of the previous tools into your health teaching at all times. Now, I have a lot of slides upcoming. They're extremely overpopulated. I tried to cram in as much as possible. I will not go over every point for lack of time, but please take pictures or whatever it works best for you. With that said, I also want to say they're overpopulated, but they're not comprehensive enough. They're just inspiration. They aren't necessarily applicable or doable in every situation, and there may be much better options in your setting. I'll also say that if anything that I mention appears to contradict anything that Erin or Mish said, they have many more years of experience in depth in their individual areas of expertise, so please take their word over mine. They're incredible humans. So I'll start with primary care settings. this is a really big list of barriers and manifestations that I was just inspired and kept going into. So goals are enforced by the provider. Rigid scheduling, appointment-based, consequences for lateness, short appointments, one issue per visit. There are risks of derostering and barriers to getting rostered to begin with. If you don't make your intake appointment, are you getting it rescheduled? Providers are limited in availability. They're understaffed. There's inconsistent availability across. When you do get a primary care provider, there's inconsistent availability of supports from social work, physiotherapy, chiropody. Again, it's siloed, relies on referrals to specialists for a lot of different conditions. They act a ton on presumptions and stereotypes, and the vast majority of the time, they are abstinence motivated in their goal setting, whether it's collaborative or not. They are based around preventative care metrics and funding, like to get their funding, and I get that. That sucks. There's also, in general, a lack of training in patients for intoxication and withdrawal in their patients. So, to reduce these barriers, what can we do? We can build rapport. Yeah, rapport building. We can also meet them where they're at, or at least for what they came for, and listen really well. Appointment reminders, I really, really cannot stress enough. Coordinating with the pharmacy to send them can be useful when folks don't have phones. Making appointments for later in the day, drop-in hours where feasible, fit-ins when it's not. I don't know how feasible this is in most settings, but if you can lengthen your visits, that would be fantastic. Having available snacks, hygiene supplies, and gift cards is super handy. There's this social prescribing phenomenon that has come up a lot recently, and referrals to social services and also uncovering those underlying needs that are not being met outside of the immediate, or outside of the acute and chronic health needs is gaining traction. Keep building rapport. Don't drop the rapport. Enough said. Collaborate. I really just want to emphasize that, don't put a plan on people. That if ideals, exercise and care plans can be handy as well, especially if there's something about a care plan that you have a nugget in you that feels a little weird. Please engage their support persons and their wraparound teams. Please engage with honesty, accountability, and forgiveness. Also, really work on that intoxication and withdrawal, how you're going to address those where possible, accepting apologies, and making sure to put principle over protocol when you are engaging in care plans, I think is important. If the protocol isn't exactly what the person is comfortable with, abide by principles instead. In emergency departments, a lot of this is very well known, and Mish also discussed this hesitance or resistance that clients experience in pursuing care that requires a hospital. A number of factors that contribute to the need for a total shift in paradigm, but on an individual level, can we do anything? Can we do anything to address long wait times, boredom, exposure to illness, cause and effect conflation with intoxication and withdrawal? There's just across the board, this stigmatization and labeling of drug seeking frequent flyers or whatever they might say. All of these barriers, really big. Short-term rapport building can happen. You can do a lot. You can make a joke. You can establish a degree of transparency that supports trust and builds rapport pretty quickly with a lot of our folks. Engaging their support persons and also reading support letters, acknowledging their complaints and concerns and validating them as very real is incredibly important. I also want to say, if it's at all possible in an emergency department, if you could interact earlier, even if you can't make the entire length of the visit shorter, that can go a long way too. Providing them updates and asking questions where feasible. Waiting room activities. If you don't have a phone, how long are you willing to sit in an ER? I ask myself this question sometimes. Whenever my phone doesn't work, what will I do? Letting people go out for a cigarette break. I feel like maybe I should focus a little bit less on going through every single part of this and take more of an opportunity to just let you have a look at it and feel like what you can see there that can be incorporated into your practice.
Madison, I think it's great. This is terrific.
Okay. All right. I will continue then. I want to make sure that we go beyond the superficial presentations that we see. Sometimes people in the ER get upset. The waiting game is a lot. Being in withdrawal, being in pain, and also having that healthcare need or healthcare needs, many healthcare needs that are unmet, is incredibly important. And uncovering that motivation, I think, would stop a lot of repeat visits that I've seen. I've had too many patients go to the emergency department and end up having the issue that their visit is classified under being totally unrelated to the reason that I sent them to the emergency department, and now they're still septic. Engaging with yourself in the moment self-reflection exercises can be really, really handy. Taking a deep breath, honestly, is huge. Where possible, if you can seek out further staff training, mentorship, and role modeling things is a good call. Role modeling your own values can go so far in helping other people, like shifting the values of the entire department and looking towards de-escalation and conflict resolution rather than reaching for some medication to sedate people would also be really helpful where possible. Going beyond that into acute and inpatient settings, we see some of the same barriers and manifestations as well as different sort of ways that they come out. So we continue to have boredom. We continue to have staff burnout. Abstinence is still the goal. We also see inadequate dosing of pain medication and sedating medications. This is something I see even more in inpatient than I do like in the emergency department. I think in the emerge, people are really used to folks who need high sort of like amounts of pain medication. But even when folks are getting their prescriptions in the setting, they're not getting something that actually compensates for the really, really high tolerance they have. And sometimes down here where I mentioned PRNs and pain scales, we have folks who have a PRN opioid medication available that in the community is there to treat their cravings or withdrawal. But in the hospital, nurses are so used to it being about pain that when a patient asks for their hydromorphone and then they're asked like, oh, you're in pain, like it doesn't come across. And sometimes folks don't take that seriously enough. Oh, there's one that just says assumptions of. That's fun. Sorry for that. I want to touch briefly on code whites, code blues, and captivity. So all of these can be incredibly traumatizing, whether they're called on you or not. Captivity, what I mean by that is this idea that you are just kind of stuck there. You don't have a lot of opportunity to get out. You don't have a lot of opportunity to engage with people. And that can be super, super traumatizing. And it can also bring back, like, if you do have experience in the justice system, bring that back. The traumatization and the re-traumatization, just continuing to emphasize that. And I also just want to touch on the touch avoidance piece that we've talked about. Therapeutic touch goes so far. I cannot tell you, sometimes I'll offer to tuck a patient in. And people, like, there's usually like a laugh and I'm like, ha, and they're like, haha. And I'm like, yeah, well, if you change your mind, let me know. And they're like, yeah, I do actually. And it's an incredible thing. And it's not outside of like what we're supposed to do as care providers. We're providing care that also helps to build rapport and trust and gives them comfort in being vulnerable. So some strategies and approaches, again, rapport building, assignment adjustments. By that, I don't mean give the person who's good at this the assignment all the time, but I do mean that sometimes it's important to also adjust things for yourself to make sure that there's a balance across the board. Collaborating with patients and coordinating their care plans. This is a great opportunity to ask them if they need something before their wound care, something like that. Being flexible in your approaches, also asking questions. I also want to just highlight this safety first piece, but don't hover in parentheses. So we know that people use in hospital settings. We don't like to know that we need to put the safety first. We need to be able to respond to a drug toxicity event without kicking them out afterwards or sending them to the psych ward or something like that. To that end, if someone is able to disclose without disclosing, that's something that I'm always comfortable with. Can you bring me something in 15 minutes? I will always go check. And I will let them know that I will go check. And I don't know what that means for my practice, but I know that that is something that I find really, really handy. Going over some of these that we've talked about already, the principle over protocol thing, what I mean by that in this case is sometimes people are in the middle of their wound care and they want to leave. And that does happen. And maybe you want to clean and cover the wound. Maybe that's not the exact, like what the protocol says, but if you can get them, like if you can do that, that will protect it when they're outside for their smoke. Then they can come back and engage with the rest of wound care. Really, really helpful to incorporate that all the time where possible. Acknowledge and validate their discrimination, their traumas, their pain, engage with curiosity and openness. When you can offer choice, that results in greater empowerment and autonomy. Again, managing the withdrawal and cravings. I know there's a lot of repeat, but these are sort of packaged together. Really reflect on what does and does not put you in danger. Address boredom, and yes, engage in therapeutic touch. Home and community I included because I think one of the things that has come up a lot is like care planning for folks when they are out of hospital settings, and maybe we're engaging with like referrals to people who provide home or community care. So when I say community here, I'm not talking about community health centers. I'm not talking about outreach. For the most part, I'm talking about like the providers who have like a contract to do wound care at a location at a given interval of time. They have large caseloads. They don't always have adequate training. I'm not talking about their wound care experience. I won't touch that right now, but inadequate training on like substance use in general and like mental health concerns a lot of the time because their focus is on wound care a lot of the time. Their care is really location bound. So if someone's not at the location that they are supposed to receive their care, not a lot of shifts happen around that. People often have safety concerns around like attending shelters, and those are often related to stigmas and stereotypes. The scheduling is inflexible, but also inconsistent. Inconsistent staff members are assigned, and the onus is always on the patient to be there when that person arrives. They also have this same lens of punishment versus accommodation for lateness behaviors or care needs. If somebody isn't taking care of their wound the way that they were told to, that can create issues. If we can train them in harm reduction, if we can train ourselves, if it's us in harm reduction and OD response, if we can role model for each other, if we can collaborate together. Also back to the appointment reminders and alternative plans. I also just want to touch on this better is better concept. Like if something will improve a thing, do it, whether or not it's the exact thing that will make it perfect. I'm sorry, was a very, like a really short, blunt way of saying that. But yes, if you can reduce the frequency so that it is less of a burden on people, please do. Alternatively, increase the frequency to address missed encounters as needed. I can't tell you how many times I've had a wound that only needed care every 3 days, but I've asked them to come every day so that half the time they get it done, and that's great. Also, like Erin said, care packages, take-home packages, autonomy and self-management, and providing education around how to do it themselves can help mitigate issues with missed appointments. Yeah. And also following up with the supports that are available that they have around them. Following up through them if somebody can't be followed up with themselves, getting consent to do that, of course. I was asked to talk about long-term care, and I admit that I have very little experience with long-term care, but some ways that I think I definitely think it's an area where we need a lot more. We need to figure out some systemic advocacy. We need to figure out workarounds. We need to continue providing these choices, these freedoms. We need to clearly articulate our expectations and the consequences. at the very least, if we're in an abstinence-based setting, we need to be very clear with people that that is the expectation. I don't know. We can, where possible, accommodate and adapt to behaviors, and maybe that's substance use, maybe that's going outside for a cigarette, which is also technically substance use. Dare I say, abstinence only policies. It's even an eligibility barrier. No smoking, no alcohol. People have these financial barriers. Places are wickedly under-resourced, and the team compositions don't address concerns of the community of people who use drugs. It is also, even more so than a hospital, sometimes very captivity enforced, like especially if you're on like a dementia ward. Locations can be far, far away from where people have community connections, and trying to figure out a way to address that is really important. People with lower incomes often have many people to a room and low privacy, or have a very small room. We also see some conflation sometimes of dementia versus psychosis versus hepatic encephalopathy. And we also have this idea that surely old people don't do drugs. That's not the case. There's punitive responses. We moralize substance use, and there's a ton of stigma from staff, but also other residents. So where we can do some safety planning, some training, utilizing external resources, and maybe establishing some transitional or tiered services if that's feasible. It's harder to make it so that this is individualized because the system is so big in this case that it's hard to really consolidate. But I'm very much here to get your ideas as well. These are just some of the ideas that I have, and maybe some of the things from other settings would be helpful as well. Finally, I'll touch a little bit on what most of us who are in attendance here already have, because I think what we think about when we're talking about integrating harm reduction is we're not us. Surely we're doing the best job already, but we are resource deprived. We're burnt out. There's a huge unpredictability of funding, public opinion, media support, client needs, the drug supply. It's also, our settings can be traumatizing and re-traumatizing. And sometimes for us, we see that as like trauma, like an opportunity for trauma bonding. Misery loves company. It's also an echo chamber, which is good and bad and great and terrible. I want to call a little bit of attention to infighting, especially as I have it set up there, outreach, social services, substance use, and harm reduction settings. We see infighting between client and client. We see this thing with clinical versus non-clinical staff. We see a thing versus in abstinence motivated and not necessarily abstinence motivated communities. And that can be really tough to sort of combat. I want us to, wherever possible, do some positive community building, some self-care. You can't pour from an empty cup. Creativity in our approaches, that helps to address the resource deprivation. System level advocacy and activism, resource sharing, mutual aid. In terms of the infighting, finding common ground, I think it's really important. And when you can't find common ground, take the high road. Maybe. I know it's hard to. I try a lot and I find it works, but that doesn't mean that it's going to work for everybody. So finding shared importance in meaning making, what works for some doesn't work for all. Empathize with people, find their perspective, diffuse conflict, share burden, like teach people, share your responsibilities, get everybody on board with the same sort of like vibes where possible. I have a little touch here about plausible deniability and keeping six. I'm not going to touch on that right now. We can talk about it at some point if needed, but strengthen and deepen your bonds with your community, seek resolution when there's conflict, and don't neglect the harm reduction needs of our colleagues either. Yeah. So I didn't touch on end of life and palliative care. I didn't touch on institutional settings like prisons or residential treatment settings, outpatient and specialty clinics, but I think you'll find that a lot of what I've touched on here can really be applied in those settings. Just wanted to highlight that. There's also a ton of other settings. I boiled down these last two slides into this patient level advocacy and systems navigation and system level advocacy and activism. So here I have things that you can do undeniably in your setting. You can sorry. The patient level advocacy is things we can all do. We can establish role clarity. We can figure out what our people are up to. We can build rapport. We can offer choices. We can empower people. We can write letters, referrals, recommendations. We can provide education and information. We can plan for challenging circumstances. We can seek out the right people to talk to and build partnerships with services. We can engage navigators, peers, and case managers. We can do assessments of social supports, and we can try to address those with referrals to community agencies. I also want to say we really need to eliminate the bystander effect. Don't assume somebody else is responsible for advocating. Learn and understand the system that you're working within and that our folks are living within. And then for systems level advocacy and activism, and this is the last slide, I talked a lot, but here we are. Some of us are in positions to change the systems we work within, whether we know it or not. We can brainstorm some ways to do that if you need to. I'm very happy to do that, but I'll just start with, if you have an opportunity to contribute to policy, government-wise or organizationally, please do. Learning the roles of your colleagues, what they can and can't do, what their areas of expertise are, how they can cross-train, and if they can, really, really important so that we're not doing that bystander effect thing. Being politically engaged and aware is really important. Doing role modeling and mentoring younger nurses, social workers, workers in general, very important. Attend communities of practice, build a community. If you can, research and scholarship. Go to conferences, speak at conferences, take media opportunities or public engagement opportunities. Really, really, really build that community when you can, because your influence is far more valuable than you realize. There's also petitions and protests and signs that you can put on your front lawn and pins that you can wear. And I smile when I see them. I don't know how much it does, but I smile when I see them, and it builds community in that sense. So to conclude, do not underestimate the value of your knowledge, experience, and your ability to promote change. And that's what I got for you. So thank you. I'm here for questions if desired. Yeah.
This is wonderful. Thank you so much. There's so much information and things to think about in terms of, where people can go with this. And I think what we have a couple of poll questions that we think will also kind of, begin the conversation, and we would invite the panelists to be part of that too. But I do invite people, if you have questions or comments that you would like to make, please, post these into the chat line as well. Just to kind of reiterate what you have been talking about in terms of the importance of the individual provider. So in other words, who you are makes a really big difference in terms of what that interaction is going to look like with your client. And, that's sort of a starting place that we really should be building into the education for healthcare professionals. And really, we should be building it into education, period, because these are the kinds of things, developing rapport, being able to consider how to do conflict management, conflict resolution. There are skills that are required to be able to do that, and experiential skills. It's not just sort of, I have a list of things that I can do. So this is really helpful in terms of being able to develop that as well. So I think if we'll pause for a second here while Tanya, you're going to get the polls up, and our other presenters can also come on board. But, and if people have specific questions for specific panelists, please do let us know. So we'll start with this poll, asking you what you would like to learn more about.
Please go ahead and ask, and I'm going to leave it open long enough for everybody to answer. people a few more seconds. Okay. Oh, no, a few more. A few more coming in. Trying to make sure I leave it open long enough for everyone.
Yes, you have to read it.
Yeah.
Yeah.
Okay, I'm going to close the poll now, everyone. Here we go. And you should sharing the results. Okay, there's a mix here.
So any comments from our panelists about this?
Yeah, I think it's really interesting to see it be so sort of even across the board. I also see like it's slightly higher on the navigating the healthcare system for people who use drugs. That is such a complex thing. I also want to learn more about peer-led models and lived experience in care. I also have a lot of feelings about how we differentiate people. Like, I'll talk about power. Like, there's just such complex things that happen in healthcare settings, and we see this like differentiation between people with lived experience working in roles as peers with lived experience versus the way that we treat healthcare providers when they have lived experience. And that can be such a very different thing. And it's something that I have a big passion about looking at.
Mm-hmm. I just want to add to that one of the comments that you made earlier about self-disclosure. You know, we certainly, when we're as healthcare professionals, we're educated to not be, not to self-disclose much of anything. And, I think what we're starting to see is a shift in the way we look at our interactions, the interactions with our patients or our clients. Yeah. To be more real. Yeah. Sorry, Mish,
Yeah. And like,
no? Yes, I thought you did. Sorry.
so I was just going to say, I think it's important to not take up space that our clients, like that is for our clients, but self-disclosure, when it can facilitate improvements in care, is really important.
Yeah, as you said before, it's not sharing your life story or your experience necessarily, but that recognition that, it's that empathic kind of recognition. Yeah.
I think what's really interesting in the harm reduction space too is building community with clients and not necessarily self-disclosure, but like political engagement that happens with our clients. Like we show up for demonstrations or community events, and we can actually be in community with our clients in a way that I think is really unique to this sector, or like speaking on panels that also include people with lived experience, doing research alongside people with lived experience and alongside actual clients. There's a really interesting change in the power dynamic and in looking to people who use drugs and the community of people who use drugs as an important voice and source of power in this sector.
Yeah, absolutely. And I want to add actually that at CHEN, we're actually working with a group right now who are developing a peer-to-peer harm reduction program. So, which is a very different dynamic than the model that often is out there, that's a much more sort of directional kind of model as well. And Patrick says here, congratulations on an amazing symposium. Absolutely. I landed on the final point of never underestimating the value of your knowledge and experience. So in seeking guests for my project, almost everyone says, I don't think I'd have much to say or offer. Absolutely. And then they give a brilliant world-altering interview. It's easy for us to lose sight of how precious and hard-won our insights are when we live in the harm reduction world every day. What feels everyday to us can be revolutionary to others. What you shared today will definitely redefine some of my practice. So, and there you've got 5 hearts agreeing with that statement. So yeah, absolutely. Erin, any comments from you about this?
Yeah, I think working in harm reduction spaces and learning from community. I think there is such. I've been thinking about wealth in a very different way recently, and we come, for those of us who are registered health professionals, we come in with a certain level of social capital into spaces, and we may also be coming in with like material capital because of the advantages of being a registered health professional. And then we sometimes look at communities that we work with and see them as marginalized, vulnerable, impoverished. And I think, yeah, like the folks that I work with, the community that I work with certainly experiences a lot of material poverty. But in every other way, it is an extremely wealthy community. And so that framing for me has actually changed my worldview about what it means to be wealthy and what it means to be strong. So I think there's a lot of bidirectional learning that happens in these spaces that is pretty unique and provides an opportunity for us to, again, as healthcare professionals, which I know maybe not everybody on this call is, but I think the majority as registered health professionals, to thoughtfully and with nuance start to push at some of the boundaries of our professional identities. And I think that will help us all come to kind of like a better place in terms of how healthcare is delivered and how it's received.
Yeah. Yeah, great. Mish, you're
Yeah, I'm talking to myself. There's been a few comments about bringing your authentic self to the work and the benefits to clients and rapport building. And I attended a talk from another nurse where she had brought up the concept of vicarious resilience. And working with this population and what kind of meaning and experience that we as providers also derive from it and the kind of strength that we get from it, and moving away from these ideas of like having a savior complex and being the person to help people change their lives, and more to like the amount of like enrichment and meaning and like benefit that we get by participating in the community as well. It's this give and take that I think is really it's really important to me, that it's like I also get a lot of benefit from my clients in my life and my experiences.
right. And that satisfaction, kind of counterbalances a lot of the things that you see and have to do when you're in those environments too. I think that's a big plus when you're working in an environment and you feel that way. Yeah, and the value of the knowledge that we exchange is more than the sum of its parts. Absolutely. Yeah, absolutely. We have another poll. Do you want to pop that one up? Oh, and it's action you take to help reduce stigma. Okay, there's an A missing, but so take a minute to look at this and respond.
Give everybody enough time to respond. And remember, if what you want to say is not listed there, you can always put yours in the chat. And give people just a few more seconds. Got 17 respondents. 18. Takes time to read through everything and
think.
and ponder. Yeah. Okay, everyone, I'm going to close it in just a couple of seconds here. Please make your final choices.
And remember, you can comment in the chat line too.
Definitely if you miss it. Here we go. Closing it now. Sharing results. There we go.
So comments from our panel?
It's interesting, building trust. Building trust is like such a process. And I think it's one where people can be easily frustrated when they think like, oh, but I'm doing all the right things. I'm using all the right tactics. I'm using the language. I'm doing my reflection. And really being aware that of the amount of cumulative negative experiences that our patients have experienced and what you embody when you walk into the room is a reflection of a lot of those experiences, and trying not to be defensive with our clients and have a lot of compassion and understanding for why they're having the reactions that they do towards healthcare providers.
Yeah, good point. Patrick has a comment here. I'm seeing a pattern emerge here of an appetite for retooling our vocabulary to highlight the strengths of communities we serve: vicarious resilience, wealth reimagined. I also love post-traumatic growth. Yeah, it's true. I mean, it's language needs to be really altered to reflect the reality of what's going on. So our clients may be vulnerable, but they're also the strongest folks I've known. Yeah. With 3 hearts. So other people, what do you think, Madison and Erin?
I wholeheartedly agree with Patrick. I think we are on this journey of the retooling of language, and I think it's important. And I consider myself drug positive, actually. So I think as humans, we are pleasure seeking. As humans, we are comfort seeking, and we do that in all sorts of ways and through all sorts of means. And I think that is great. I don't think it's great that we live in a society where some people can access the things they need to feel well in a safe way, and some people can't. So I am drug positive, and I am system critical. So, for me, if I'm working with someone and they're like, my dope is really good today and I feel good, I'm just like happy for them, and then just being drug positive as a person, I think that goes a long way, and people can pick up on that pretty easy. I think my co-presenters would agree that if you start from this premise that like drugs are bad, but I'm going to work through so that I don't come across like I think drugs are bad, and you're actually just like, yeah, we use drugs in lots of different ways, and that's okay. They're cool. Everyone who goes to the doctor is drug seeking. Why else would you go to the doctor, right? Um, uh, so I think, yeah, I guess to Madison's point, like doing that work in your own brain is, I think, the biggest thing that we can do. And then, yes, to Patrick's point, finding ways to have a better common language around this stuff. Sorry, Madison, go ahead.
No, I'm sorry. Also, I deleted two slides about the substance use continuum, which I imagine you're familiar with. One of them was the substance use continuum that is like the government one that says like non-use to like non-use, then beneficial use, and then such and then dependence at the end. It's like this continuum. And then I had like edited it in the next one where I was like, I actually think beneficial use and non-use are like whatever it means to you is like I don't think that beneficial use is worse than non-use. And that was like I deleted it for time and also for placement but it was very like it's important to, and one of the like, most difficult things to challenge is this like socially accepted assumption that drugs are bad. We like it's so across the board in most professions, most areas of our society that drugs are bad, except when a doctor prescribes them or a nurse practitioner. Maybe that then they might be bad too. We'll see.
Or alcohol.
Yeah, alcohol, such an caffeine.
Mhm.
I
When
think
you start to think about all the different substances that people use in order to alter their current reality to feel better, there are a lot of different things that people use in that respect. So, but as you talked about, I think at the very beginning, I think actually it was Mish, your presentation when you were talking about, sort of how prohibition and that whole sort of concept of it bad, bad, like doesn't matter, it's bad, right? As opposed to sort of really being able to think about, well, actually, what is going on here? Yeah.
I think it's so important, and it's like so nuanced, and two things can be true at once, where people have a relationship that they've identified as problematic with the substance that they use, but at the same time there's a reason why they're using it. They do get a benefit, they get a euphoric effect, they get coping with the circumstances that they're dealing with. We see people, like, I think about utilitarian use of substances, like if you're sleeping on the street and you use meth to stay awake all night to protect yourself against assault. And if we're trying to have conversations with people when they do want to change their substance use, we need to look at both those negatives and also the positives that they're getting from it, because they need to be able to find alternative ways to meet those needs if they're going to be able to make changes. And I think I like that drug positive. I can feel the like immediate negative response that it could have. But if we think about it in terms of like sex positivity, and we're not saying everyone should just do everything and do all the drugs, but yeah, if you come to that conversation and show that you have a nuanced view and that you can see the positives that people also get from it without, even when people are wanting to change, it makes such a difference to being able to have that conversation and also being able to figure out like what's going to work for that person when they want to change.
Right. And then, another part of that whole conversation is going back to even wound care and looking at, I always think about, treat the underlying cause. So when you look at people who are doing things that are, whatever, potentially negative, what is the reason for doing this in the first place? Like, where is this coming from? Is it coming from they had an injury, an accident at work that was never resolved, and they live with chronic pain? How do you deal with things like that? How do you deal with poverty? How do you deal with losing your job or losing your family? All of those are causative factors that we also should be looking at as we are going through this as well. Yeah. And Madison, you have a comment here. There's also self-fulfilling prophecies and cycling that happens when we engage with our substance use with a lens of internalized stigma. Ooh, that's a that's a whole thing that we really could be talking about, right? If we
I
had
could
more
talk for hours.
yeah,
I
well,
won't though.
not today, but so maybe we can go to I think, do we have one more poll, Tanya, or?
We have two more polls.
Great. Okay, well, let's
Okay.
hit the next one. Yeah. So what is your biggest barrier in implementing harm reduction in your region? So we realize, lots of barriers here.
And if yours isn't listed there, please add it into the chat.
Yeah, absolutely.
Just waiting to see if we can capture as many participants as possible. If anyone's deliberating, just a few more seconds. Add in your comments or your answers. Okay, I'm going to end the poll.
Okay.
There we go. And we've got some people who have commented in the chat as well.
Mm-hmm. So Tanya Tercero, I'm sorry if I'm not pronouncing your name properly, in your unit. So yeah, you work in a postpartum area. So besides education to the patients, they fail to take care of the C-section. Great. Good. Yeah, so the other issue, people tend to get really focused on the whole notion of it's the drug seeking or the drug dependence that's the issue. Mm-hmm.
I'm just leaving this up so everybody can see the proportion who say it's funding versus political opposition versus public stigma. There's no logistical challenges reported versus lack of training, and then we have other.
Yeah, so what do our panelists think?
Well, I'll say it's very these top three are so linked to each other. Public stigma creates political opposition, reduces funding, and we exist within this system that really is designed to sort of keep the Ouroboros. Never mind. The snake that eats its tail.
Oh, right. Yeah.
It is so intertwined, and I try to keep a little bit of hope in what feels pretty dark right now in terms of harm reduction and the political backlash that there's been so much backlash to past interventions too, and things that are totally accepted as medical practice now, like methadone, for example, had a huge backlash when it was first introduced, had a huge backlash again through the 80s where people said, this wasn't the role of medicine for people to be prescribing drugs to people who are quote unquote addicts. And I try and keep in mind that this is just another one of these cycles that's happening. And it doesn't mean that things are destroyed, that we will win again. These things just go through these cycles and can be recognized again in the future as really important interventions.
Mm-hmm. Mm-hmm. Erin, any comments from you?
I agree with Mish. I think we have a moral obligation to remain hopeful. Even though certainly in Ontario, where Mish and Madison and I are, things are very difficult right now. And I think it's so important that we all remember and carry close with us the fact that the drug prohibition laws that exist in the nation state of Canada and the nation state of the United States are based in colonial, xenophobic, racist policies. And that is still the major driver of drug laws and drug policy. So I think this is really a time in so many ways where we're being called to radicalize a bit, to really, really work in solidarity, because there's a big task ahead of us, and I have great faith that that we're going to see the kind of world and the kind of services that we need. But yeah, it's a lot of work ahead.
Mhm. But it really, what I think about too, when I see the number of people who are on this symposium, makes me feel also very hopeful that, people are beginning to really open up and recognize that these are important issues, that they touch everybody. I mean, that's, I think, the other thing too. This is not something that happens to people who are, you know, who are kind of under the bridge. When you think about where are the issues, they're everywhere. They're across the board. And part of what we need to really be looking at is, how do we increase the knowledge, and decrease that notion of the myths and the stigma that is attached to what we are looking at here, because it's the same kind of thing when you think about a number of the other issues that come up around binary thinking, that create this sort of problem where it's right or wrong. It's, people are addicts or not. There's this whole sort of notion that we need to move away from that perspective. And you have all really talked about it, I think, as well. And all of these points are really important. But certainly when we think about political opposition, needs to be, the political system needs to be altered by advocacy and, political action and advocacy. And the way we can do that is educating people more on what it is that they should know about. So, I think things like this symposium, are really helpful to be able to do that. Certainly that's the driver behind the harm reduction worker certificate program that we're in the process of getting set up for the fall, because this is something that is really important for people to be considering in their practice. Certainly in healthcare, we need to really look at this.
I'm going to run our final poll.
Yeah.
And
So this
again,
poll, which harm reduction approach would you like to see prioritized? Again, this is, tough, right?
and if you don't see other is not at the bottom, but if you have something else to add, please use the chat. And just giving everyone enough time to respond. Here we go. I just moved my microphone closer to my mouth. Hope you can hear me. Just giving everyone a few more seconds to reply. And looks like everyone's responded. That is going to. So I'm going to end that poll. If anyone wants to comment in the chat, if there's something that you'd like to add that is not there, please go ahead, and ending the poll. And here are your results.
So panelists, what do you think here?
As a safer supply provider, I love seeing safer supply come up there. And we need all of these things. It's hard to choose a single one because they all work together, and we need to be, this is such a complex crisis, and we need all interventions on board to try and tackle it. And I think about, there's a great podcast called Crackdown that I recommend checking out. And the host, Garth Mullins, said in a presentation, when I hear the sound of a naloxone vial being cracked open, I hear the sound of an upstream failure. That if we're coming to the point of people, nearly dying and needing to be revived, we've missed so many other places to intervene at that point. So like, as important as naloxone distribution is, we need to be addressing, the root causes of this crisis. And a lot of it has to do with criminalization, and with how criminalization produces these conditions that lead to overdose and lead to a really toxic drug supply. So safer supply, whether that's medicalized or non-medicalized, compassion clubs, I think is extremely important, because it's the supply itself and the dangers around the supply that's producing a lot of the harm.
Yeah, and you just articulated the very crux of harm reduction, Mish. Yeah.
Yeah, I can't add to that.
Yeah, and can you provide the link to that presentation that you're referring to?
Yeah, I can provide the link to the podcast in the chat there.
The podcast, yeah, that's great.
Crackdown podcast is great. And I don't know if Patrick wants to share, but he also has a really great podcast.
So Patrick, maybe you can share that.
If you want.
Great, yeah.
There's Patrick.
Okay, 1 sec.
One sec.
Well, what it demonstrates to me also is that, this is a collaboration. I mean, this is an opportunity for us to really think about, how do we collaborate more? How do we network? How do we share the resources and the knowledge? And how do we look at this across the country as well? And, certainly with our colleagues elsewhere in the States, I mean, these are things that cross borders. They're certainly not, unique to one place or another. So Patrick has posted here, walking radio available on Apple Podcasts. That's really great. Conversations in motion, centered stories from the front lines and the margins. That wonderful. So we'll make sure that also gets noted when we're putting the recording together as well. So I really, this is amazing. I just have to say, I think this is amazing. Maybe we can stop sharing that poll. Can you do that, Tanya? Just get that out of our field. What I really want to do is, just say that how fabulous this opportunity was. And we do have another little piece that we want to share with you, really exciting about our plans for the fall. And our plans for the fall will involve these 3 amazing presenters again, in a slightly more in an opportunity to really go into more depth as well. So I want to thank you profusely for being able to present the way you have, to demonstrate your knowledge, your passion, your expertise in being able to talk so eloquently about this topic. And I want to I want to just turn this over to my colleague Tanya Sherry, who is just going to give you a little bit of a highlight of what our plans are for coming up for the fall.
So, Rosemary, you may be the better one to talk about this, but our goal is, and this has been honestly something in the works since we were at York University here in Toronto, is getting something a little larger going for harm reduction. And Rosemary has been working with Erin, Madison, and Mish on this wonderful certificate launching this fall. It's for this will be very inclusive. It's not just for healthcare providers, but we're looking at peer workers, outreach staff, and healthcare providers, so that it really includes as many people as possible who are on the front line. And Rosemary, can I turn it over to you just to talk a little bit more about what it will cover? And then, but I'll just quickly say it will be micro-credentialed online. It'll be a professional postgraduate learning, and it's short duration. So you can get back into your roles applying it.
Yeah, absolutely. Do you have another slide that covers or specifically the...
There you go.
Yeah, so that's great. So, what we really, and I think what the other thing I want to say too is that when we talk about postgraduate, what we really mean by that is this is not, it's a continuing education program. So it's a continuing education certificate, which is what most of these kinds of programs are. But the main thing is that it provides an opportunity for a deeper dive into harm reduction principles, talking about the things basically that were discussed today as well, and really looking at the populations that are at particular risk and being able to speak to that as well. But we are encouraged by the interest across the board for this kind of work to be done, because I think that we are seeing, certainly what I've seen in the medical literature, is a beginning interest in recognizing that this is an area that we really need to pay attention to. It's not going away, and it's something that, from a healthcare perspective, a lot of our healthcare dollars are being spent downriver, as opposed to really looking at, how do we deal with this in a way that is going to be much more effective. So that's one of the, components that we're really going to be talking about, and looking at this from an advocacy, systems navigation, and an action perspective, because it's one thing to talk about all these things, but we need to make sure that we're actually moving in a direction where we can shift that paradigm to think more, to get, the political perspective changed to really address the kinds of things that have been talked about today. So yeah, was there another slide? Yeah. So please, the registration will be ready to go probably, I would say probably early in the summer. So, subscribe to our website, to our podcasts, to our newsletter. You'll be able to get more information about this as well, and the other courses that we offer too. Tanya, do you want to?
Yeah, if you are interested in more information, just email us at info@chennetwork.ca. It's up on your screen, and I will, as soon as I have all of the information ready to go, I'll have you on the list and I'll send it over to you.
Great.
Yep.
So everyone, we're ending a few minutes early. I would like to just thank our presenters today. So Erin, Mish, Madison, what an excellent time. The only other thing I want to say is that as an old nurse, it's really nice to see young, dynamic nurses working in this area. So just, I just really want to thank you for doing that. So thank you. And thank you everyone for being here and for being as involved in the conversation and the discussion as you have been. So kudos to everybody today. And I wish you a wonderful weekend. Peace, as much peace as you can take out of the air. So thank you for being here.